children can be complex and often frightening for families, but many of them are treatable and often reversible with timely recognition and appropriate management. The upcoming session will highlight the importance of early diagnosis, discuss common treatable neurological disorders, and emphasize the profound difference that intervention can make in a child's development and quality of life. To help us understand the fascinating intricacies of neurology, I would like to welcome the moderator of this panel discussion, Dr. Arpita Adhikari. Ma'am is an additional professor, Department of Pediatrics, Division of Pediatric Neurology and Epilepsy. She is a fellow in Pediatric Neurology and Epilepsy from the State University, New York, and also MUHS. She has done her PG diploma in Developmental Neurology from Kerala University. With 15 years of experience in this field, she is instrumental in starting the pediatric EEG laboratory in our department and running the epilepsy services in LTMGH. May I call upon our esteemed panelists, Dr. Mona Gajre, Dr. Shekhar Patil, and Dr. Neelu Desai. Dr. Mona Gajre is a professor, Department of Pediatrics, and the in charge of Pediatric Neurodevelopmental Center, LD Clinic, and Neurology, Epilepsy, and Developmental Pediatrics at LTMGH. Ma'am has been the ex-chairperson of the IEC at the HI Media Laboratories and is also a member of the Society of Development and Behavioral Pediatrics. Dr. Shekhar Patil is a consultant in neurology at Apollo Hospital, Navi Mumbai. With over 20 years of experience in the field of neurology, he has earned recognition as a leader in the diagnosis and management of complex neurological disorders. Dr. Neelu Desai is a consultant pediatric neurologist at TD Hinduja Hospital. She has considerable experience in the field of epilepsy, electrophysiology, as well as clinical neurology. She is an active member of the epilepsy surgery team as well. I welcome you all, and over to you, Dr. Arpita, ma'am.
Thank you so much, Aditi. Welcome all of you after the post-lunch session. I can promise on behalf of myself and my panelists, we are going to make it very interesting. So I know after lunch we feel a little sleepy, but I'm sure as a pediatrician, each one of us want to make an early diagnosis, and we do not want to miss the disorders that are treatable. So we are bringing to you some 4 cases, although there are many other treatable neurological disorders, and we take it further. So the contribution of non-communicable neurological disorders has doubled from 4% in 1990 to 8.2% in 2019. Many of these disorders come to pediatric in office practice as non-specific symptoms leading to delayed diagnosis. Missed recognition can result in long-term cognitive, motor, and behavioral deficits, and early detection and intervention can transform outcomes, and this reduces the disability and improving the quality of life. So we begin with case 1. This is a 9-month-old boy born of non-consanguineous marriage with normal birth and development, who presented to us with complaints of gradual loss of previously acquired milestones at 6 months of age in the form of reduced babbling, poor eye contact. He stopped sitting with support, which he was doing earlier. He started having onset of coarse tremors, 2 months followed by regression of his milestone. These tremors were affecting the limbs and the head, worse during activity and absent during sleep. According to the mother, the child used to be very irritable and cranky. These were his examination findings. He was having severe acute malnutrition, apathetic look, not interested in surroundings, severe pallor, sparse brown hair, reticulate pigmentation of the skin, knuckle, and perioral areas, as you can see in the picture. On examination, he had hypotonia, preserved reflexes, and these are the tremors, if you can see, that he's having tremors of both the upper limbs. He's shaking his body, and now if you can see, there are perioral tremors as well. There was a mild hepatomegaly present. So in summary, this is a 9-month-old child He's having neuroregression, coarse tremors, pallor, irritability. These tremors disappear in sleep. There is some perioral hyperpigmentation and sparse hair. So what would be the differential diagnosis? So whether it is a neurodegenerative disorder because there is neuroregression present, whether it is a metabolic disorder because the child has some hyperpigmentation, or it is an infantile tremor syndrome. So investigations done by us, CBC was HB of 7.8, microcytic hypochronic anemia. Serum B12 levels were 71. His MRI brain just showed some mild cerebral atrophy and delayed myelination. Then on inquiry, after looking at all this, the mother said that she is a vegetarian and the child is exclusively on breastfeeds. So the final diagnosis was an infantile tremor syndrome. Child was given vitamin B12 in the following schedule: 1000 microgram IM daily for 1 week, followed by 1000 microgram alternate day on the week 2, 1000 microgram once a week for 4 weeks. Oral iron and multivitamins were also started as he was anemic. The response was just wonderful. Tremors reduced significantly by day 5. The child became alert. There was social interaction by week 2. And there was gradual recovery of milestones over 4 to 6 weeks. So now may I ask Dr. Mona Gajre, what is the classical tetrad for identifying an infantile tremor syndrome?
Yeah, so thank you for this good case, Arpita, and nice video. So, for the tetrad for infantile tremor syndrome, you can have pallor as a primary presentation, hyperpigmentation of the skin, and there could be sparse brown hair which is there. And what is more important to note is that tremors is not part of this tetrad. And the important thing that the children come to us, of course, is developmental regression or regression in milestone, which was there in this child, right? So all this forms part of an infantile tremor syndrome. And I remember as a resident, we used to see it pretty commonly earlier, but nowadays we do see it infrequently, but it is not as infrequent as this. It is important that when we have any regression in the milestone to always remember treatable conditions, and infantile tremor syndrome because of vitamin B12 deficiency could be part of that. So the important, again, to highlight, tremors is not part of the tetrad. Sometimes, in fact, you can have tremors preceding the presentation, or the tremors can come later, and it is called as pre-ITS kind of a presentation.
Thank you so much, ma'am, for the reiteration that although it is called as infantile tremor, as ma'am said, don't wait for the tremor to come in. If the child is having neuroregression, there is pallor, there is irritability, and the kind of hair as described, then please go ahead by doing a serum vitamin B12, and we'll further talk about what the investigation should be. Neelu ma'am, can you please highlight what kind of tremors are a hallmark of this disease, and how can one pediatrician in office practice identifies them?
So these are tremors in infantile tremor syndrome typically involve the hand, the perioral membranes, perioral mucosa, and sometimes even the tongue. If you open the mouth, you can actually see the tongue tremors also being present. These typically, like any movement disorder, they disappear in sleep. They become reduced, markedly reduced, or disappear in sleep. They may be intermittent. Typically, they may be precipitated. So a child may be background B12 deficient. Remember, B12, sometimes the reports may be normal of B12. So you may have to go for surrogate markers like homocysteine. The background may be that B12 deficient, and there is a infection or some gastroenteritis which may just trigger off these tremors. And often they are misdiagnosed as convulsions. So we have had cases where they have been on treatment for status epilepticus, on midazolam drip, but actually these are tremors which are typically involving upper limb, face, and your tongue muscles. So this is which is very typical of this. Sometimes there may be tremulous speech also, because of which, like bleating, you have mentioned, I think, bleating of goat. Because of when they try to cry, it may be a sound of a bleating goat, which may appear like that.
Yes, thank you so much, ma'am, for that. Shekhar sir, now this child has come to my office practice and his serum B12 is normal. So is it still ITS? Should I still consider ITS, or what should I do further?
So even with a normal normal B12 with the classical presentation, you will still consider infantile tremor syndrome. So having a normal B12 is not against it, but as Neelu said, yes, you can do the surrogate markers of methylmalonic acid as well as homocysteine and probably define. But you also need to remember that there are other deficiencies also, like zinc, iron, magnesium, which also should be part of the supplementation when you try to treat a child with ITS. And in a few settings with the ITS, you can actually trigger, when you give the B12 and the correction begins, you can actually trigger seizures also. So you should also be wary that it may happen, but it is part of the treatment. You don't have to really continue treating them as epilepsy related.
Okay, thank you so much, sir. And we as pediatricians, we see that most of the kids are on multivitamins. So the B12 also could be normal. So the studies, as Shekhar sir has already mentioned, in 10 to 15% of the children, the serum B12 is normal. Mona ma'am, can you tell us that how does an early recognition help in these children?
Yeah, so as I said that this is one of the very treatable conditions, and so early recognition, as for everything, is always better, primarily from the point of the milestones. Okay, so if you have, as Arpita has said about this case, this child had a loss of milestones in the motor as well as in the social and communication domain, and after B12, there was a reversal in symptoms. I mean, that is magical, especially because in certain conditions where you have the neurodegenerative or neuroregression kind of syndromes, you may not see, you often do not see a reversal. So this kind of reversible is very, very dramatic, very heartening for the parents. So definitely early recognition is important because rapid reversal of symptoms is there. Also, even if you kind of treat them, you prevent really the regression and the developmental delay. As Shekhar sir and Neelu madam has also mentioned, always check for the mother. Like in this case, the mom was a vegetarian. So, but often even in non-vegetarian people, maybe they are not eating the required consumption, and then you could have a B12 deficiency. So it is required to either check the B12 levels of the mom, or you could also, you also need to supplement her for preventing B12, because these are quite often breastfeeding babies. And as we saw in this baby, there was a case of SAM, that is severe acute malnutrition, and we need to supplement them in addition to the B12.
Thank you so much, ma'am. So for the residents, every child who has neuroregression need not be a neurodegenerative disorder. As we have discussed throughout the panel, just remember the tetrad and the coarse tremors, which are a hallmark. So what do we learn from this? Infants with developmental regression rule out ITS. Though coarse tremors are a hallmark, they are seen only in 20 to 50% of cases. Increased homocysteine levels, as mentioned by the esteemed panelists, are more sensitive than B12 levels if the child received B12 supplements recently. And early regression and treatment with B12, as ma'am has reiterated, prevents developmental regression. Coming to my next case. Sure.
This child had typical ITS, and he was SAM. So SAM children who are malnourished can have a lot of hypokalemia. And when you give massive dose of B12, like you give 1000 microgram, it can drive so much of potassium in the intracellular space that he may actually die of hypokalemia. So I think we always give only 10, 20, 30 microgram per day for the first 2-3 days, see that he tolerates well, and then gradually build up. I mean, such a small child, even 100 microgram is enough. There's no need to give 1000 microgram.
Yeah, so to reiterate, I remember Mangalani madam is also here. For all our B12s on day 1 of life, day 3 and day 7, even before discharge, we used to do the potassium levels. Your point is well taken, sir.
Yeah, thank you so much, sir, for telling us the point that we missed, that potassium levels need to be checked in a child who's been given serum B12. So coming on to the next case, a 1.5 months old baby girl. She was born of 3rd-degree consanguinity, normal by birth. She got fever after vaccination. A whole cell pentavalent vaccine was given 1 week prior. After that, she had multiple paroxysmal events since 6 days in the form of jerking of all 4 limbs, uprolling of eyes, lasting for a few seconds. But the mom said that she was active in between episodes. She was admitted in a tertiary care hospital, treated as sepsis with amoxicillin, followed by meropenem, phenytoin, levetiracetam. The fever subsided after 5 days, but the seizures continued, and hence the child was referred to Hinduja Hospital and taken care of by Neelu ma'am. So the examination findings showed that the weight was between 3rd and the 5th centile, 50th centile, length was 54 centimeter, head circumference 38, no neurocutaneous markers, child was not having any dysmorphic facies, no skin rashes, scalp was normal. If you can see over here in the video, you can see that jerk, that she had just multiple paroxysmal events, myoclonic. She turned first to the right. Yeah. Her vitals were normal, but as the child was on AEDs or otherwise because of the disease, the child continued to remain drowsy. So course in hospital, in view of persistent seizures, the child was loaded with injection phenobarbital, followed by maintenance. Levetiracetam and clobazam was continued. If you can see over here, the child is having subtle seizures. Yes, she is just lip smacking, her tongue and lip movements are present. No response. The child also had intermittent hiccups. I have the next video of the hiccups. So in summary, she is a 1.5 months old female child. She got fever after vaccination. Fever was associated with multiple episodes of seizures. Even intermittent hiccups were very, very prominent. Drowsy, not responding to 3 anti-epileptic drugs. So what should one consider the differential diagnosis to be? So generally, when the child is having fever, vaccination and seizures, we would think of maybe it's acute meningoencephalitis, whether the vaccine was given 1 week back and whether this is vaccine encephalopathy. Every neonate or paraneonate, we need to consider a metabolic seizure, late onset HDN, in view of intermittent hiccups, whether she was a case of non-ketotic hyperglycinemia or she was a case of pyridoxine-dependent epilepsy. So doing the investigations further for this child, her CBC and CRP was normal doing the infective workup. Serum electrolytes, calcium, magnesium for metabolic workup was normal. Yes, biotinidase is a very important thing. As we mentioned in the history, there was no scalp changes. So TMS with biotinidase was done and that was normal. Serum ammonia was normal. We ruled out NKH. As you can see over here, the child had excessive hiccups. So non-ketotic hyperglycinemia is one of the differential diagnoses when there are hiccups. CSF was normal. CSF culture showed no growth. CSF to plasma glycine index also remained normal. This was the EEG which was done of the child. And if you can see, there is a burst suppression pattern. There are generalized bursts that are present. So after giving injectable pyridoxine under EEG monitoring, this was the response to the EEG. A dramatic response, the EEG normalized. After 48 hours of B6, it was a completely normal EEG. Further course, MRI brain was done. It was normal to rule out anything else. Post B6, the seizure stopped. Phenobarbital was withheld as the child was already very drowsy. Pyridoxine was then reduced to 50 milligram daily. The child was restarted on breastfeeding, sensorium became better and discharged on oral pyridoxine 100 milligram daily. Biomarkers of pyridoxine deficiency were sent, CSF pipicolic acid high, ASA was high, whole exome sequencing confirmed the final diagnosis. This was a case of pyridoxine-dependent epilepsy, ALDH 71. So Neelu ma'am, can you please highlight what are the clinical features should one pediatrician suspect for a pyridoxine-dependent epilepsy?
I think any child below 18 months, till the age of 18 months, if any child comes with seizures, refractory seizure, one of the differential, especially if it does not respond to your first line anti-epileptic, pyridoxine dependent epilepsy should be suspected. In this case, there was a third degree consanguinity that already 3 anti-epileptics were given. He was not responding. Generally, all such children, we have to give them a trial of pyridoxine. If pyridoxine does not work, then pyridoxal phosphate, folinic acid, biotin. These are the usual things which vitamins, multivitamin responsive epilepsies where you have to give them. It's not just newborn period of first 3 months. Sometimes they may come later also. So in those cases also you have to give it.
Yes, thank you ma'am. So the typical case, as ma'am said, of PD would be in the neonatal period, but the atypical cases or many other cases come up to a later period also. Mona ma'am, can you say that what would be the response to anti-epileptic drugs and to pyridoxine in a case of PD?
So as Neelu madam said that, if the child is not responding to your first line anti-seizure medicines, then especially in the newborn period and in the infancy period, we should think of pyridoxine-dependent epilepsy or this. So what happens is the response, we've seen that in this case, that the EEG is showing a burst suppression pattern, and when IV pyridoxine has been given, there is a dramatic response, and that is really what occurs in these children. So you see a dramatic response, and more so, you would say that it is dependent, as in other conditions, that when you withdraw the drug or you stop the drug, the seizures recur. So that is essentially more diagnostic for a pyridoxine-dependent epilepsy. More often than not, these children do have a little developmental delay, and they may have a cognitive delay. And though you take care of their seizures even earlier on, maybe the cognitive delay still remains. So that is the thing.
Thank you, ma'am. So Shekhar sir, this child has come to a center where EEG facilities are not available for a para-neonate. So still can injectable pyridoxine be given?
No, I would not actually. I would do it only under EEG guidance because you may trigger electrocerebral silence with IV pyridoxine. So you should not even attempt. But you may probably go ahead and give oral pyridoxine, which may take a slightly longer period, but it will work.
Okay. Neelu ma'am, can you tell us about the treatment protocol for PD? Is it only pyridoxine and pyridoxal phosphate, folinic acid, or any other interventions also to be done?
In addition, you can.
Yes. So can you just elaborate why empirical? What do you mean by?
Actually, triggers that the EEG actually goes flat. So you should not attempt IV pyridoxine in a setting where EEG is not available. You cannot decide on when to stop. So you're giving, and then you don't even know what will happen subsequently. So the electrocerebral silence is the danger when you are giving IV pyridoxine without the EEG monitoring.
So a further question to it, how would that electrocerebral silence manifest in the child? Like he's already seizing, so how would it manifest?
So it will stop.
Yes.
Apnea. So it will stop. So everything will stop.
So is it if
In
the
an
child
ICU
is in
setup
ICU
where
setting?
you have the monitoring, you can give it.
Exactly.
But if because respiratory depression can occur, but if there is ICU setup not there where you can't monitor, if he is already in ICU, ventilator ready, everything, I think you can give. But if it is not there, then sometimes it can cause severe depression, respiratory depression, it can cause severe sedation also. So in this child also, as you saw, he became very drowsy despite stopping phenobarb, he was very drowsy, so we had to decrease the pyridoxine. And once he was stable, then we increase it to the usual dose.
Yes. So the point well taken, if EEG facilities are not available, but if the child is in an ICU setting, where there is good monitoring of apnea and this is done, then yes, IV pyridoxine should be given. Otherwise, it should be avoided. Yeah. So ma'am, can you tell us about the treatment protocol for PD and any other interventions?
So generally, we give it try of 100 milligram or 30 milligram per kilogram. we give a try, and if it does not respond, you can go up to pyridoxal phosphate, 3 to 5 milligram per kilogram. If that does not, if it is effective, then you have to continue. During illnesses, you have to double the dose. So because the requirement may go up, so in increase illnesses, you have to double. It has to be divided into 100 to 500 milligram IV, as it's mentioned. Pyridoxal phosphate dose is 30 milligram per kilogram. We have syrup preparations available now for pyridoxal phosphate. And for pyridoxine also, we can give oral, or we can give injections which have 30-35 milligram, and you have to accordingly increase the dose, and you have to give the pyridoxine preparation. Optineuron and all, they have little higher concentrations which you can give.
Any other dietary interventions, ma'am?
Yeah, they have this restriction of lysine, which is also found to be effective in these patients. So lysine restricted diet is something which has to be given.
Okay, thank you so much. So what did we... Yes.
Yeah, there are certain, I think, pulses or something which need to be restricted, nuts, pulses.
Is what? Cereals can be given because cereals are deficient in lysine, and as ma'am said, pulses should be avoided.
Certain pulses.
You know, I have a basic question. You know, we are fortunate to be in the city with so many intensive cares and high EEG facilities. And 90% of India, you know, babies will not have these facilities. So is there any way of them trying it out? They can't all bring them to cities to do the EEG and do the EEG monitoring. So what would you give to, say, pediatricians in general or doctors in general outside city limits where EEG?
Oral pyridoxine tablet comes, tablet, that can be crushed and given easily in these cases, where ICU monitoring or respiration, oral medicine, and even oral syrup for pyridoxal phosphate is available, which can be given in these.
I think that has to be told, because we don't everybody does that. Great, that's nice.
Yeah.
And as Mona ma'am had mentioned, compliance with pyridoxine is extremely important, as one of this is withdrawal leads to repeat seizures, recurrence of seizures. So yes, as the esteemed panelists have already mentioned, PD has a wide phenotypic spectrum with myriad of neurological and systemic symptoms. Hallmark is refractory seizures, and as Neelu ma'am said, not only in the neonatal period, but from first month to 3 years of age. Not all children respond immediately. Early B6 and lysine lowering strategies will definitely better cognitive and developmental outcome. Coming to our third case. So this is a 5-year-old boy born of non-consanguineous marriage with normal birth and development, who presented to us in emergency with chief complaints of he had gradual onset of behavioral disturbance. Mother said that he was very irritable, just became emotionally labile, social withdrawal. There was a disturbed sleep-wake cycle which started 2 months ago. Now, after 2 months of these complaints, the child comes with one episode of generalized tonic-clonic seizure which lasted for just 5 minutes. And just after that one seizure, the child became encephalopathic. He had reduced responsiveness, he was extremely agitated. He also had perioral dyskinetic movements, as you can see in this video. He has perioral dyskinesias. There was just some fever with some generalized rash, nothing very specific, that was there 3 months back. So on examination, child was irritable, GCS score was 12/15, his cranial nerves were normal, motor was normal, tone power, there was no focal deficits, reflexes were normal, plantar flexor, no meningeal signs, no autonomic instability, just perioral dyskinesias. So just to summarize, a 5-year-old boy, he has had a subacute onset of behavioral changes. For the first 2 months, he just had behavioral changes, followed by one episode of seizure, and that seizure tipped him into encephalopathy. He had this perioral dyskinesias. So what would be the differential diagnosis? So because he had some kind of fever 3 months back, should we think of post-infectious or inflammatory sequelae? In this, sir, you are the boss. So in this, Should we think of non-convulsive status epilepticus because he has become encephalopathic for the residents? Whenever, you cannot explain the encephalopathy, that one seizure is not going to lead to encephalopathy. Or should you think of autoimmune encephalitis? We got our answers, but I'll go ahead with the investigations. So EEG, yes, is very important. You get delta brushes. MRI brain needs to be done to rule out anything pathognomic. MRI brain was normal. CSF routine and culture was normal. As a child had fever prior. We sent CSF NMDA antibodies, which turned out to be strongly positive. So the final diagnosis was NMDA encephalitis. Child was given IV methylprednisolone, 30 milligram per kg per dose for 5 days, followed by oral prednisone for 4 weeks. Response, there was a significant improvement in sensorium and behavior within 2 weeks of completing the course. The dyskinesia is completely resolved. Now the child has no further seizures and the immunotherapy is tapered. So Shekhar sir, can you tell us when should one suspect autoimmune encephalitis?
What you've shown is someone who probably, it will not be the typical scenario when they come to us, but if you have someone who has a sleep disturbance and the encephalopathy, seizures and movement disorder, of which perioral dyskinesia is the classical variety, you would strongly think in favor of an autoimmune encephalitis. But most of them would come to us primarily with seizures and unrelenting seizures like a status epilepticus. So you would probably see a scenario more often of what we call as NORS, and where one of the differential would be autoimmune encephalitis. So the classical thing would be highly, I won't say that it's common, but it would be the one that you will follow up, then you will actually, the whole picture may emerge over time. So once you start the treatment, sometimes the movement disorder comes later on also.
So sir just said NORS, so they can also come with new onset refractory status epilepticus. Moving further, Mona ma'am, can you just tell us what are the investigations that would support the diagnosis? As Shekhar sir said, the history of an autoimmune encephalitis can unfold. It can be variable. So what in the investigation should one do which will support and tell us that yes, this is autoimmune?
Yeah, so as sir said, NORS or status epilepticus could be primary presentation. Here at Sion, we have seen cases with primary or neuropsychiatric manifestation. As sir said, sleep disturbances is the first thing. And nowadays, as we know that taking a sleep history is so vital to us, even as pediatricians or as specialists or super specialists, which is there now in pediatrics. So sleep disturbances in a child who was sleeping earlier, a little confusion, a little irritability, scholastic performance can be a little altered. So going by that history, then the movement coming up, a little progression more to encephalopathic behaviors and encephalopathic pattern, and the movement coming in. So with that constellation of symptoms, one should go ahead with the investigations. And Arpita, as you rightly said, because that child had this history of infections and in a setting that we are in, LP is of course the primary things that we do, which often is negative. The MRI is what we do, though we have mentioned our limbic system changing, more often than not our MRIs are normal. EEGs, the classic is the delta brush, but again, I have rarely seen that over here. What is the clinching thing? So it is almost more like you're thinking this is the constellation of symptoms. You're doing the investigations, your standard ones have come negative, you go ahead with an antibody. And the antibody, the NMDA one, is what would kind of give us more the answer to it. Again, as Arpita has also mentioned in this slide, is that one should look for triggers. So in young children, in women, in females especially, ovarian teratoma is the commonest underlying tumor which can be associated with the NMDA or encephalitis. So in our children, like this child also, we had done a USG of the abdomen, etc., to rule out for tumors. So that would kind of be part of the workup.
Sure.
Anything
Thank
else?
you, ma'am. Would you like to add?
The only thing about NMDA, you have to be very aggressive for the treatment. The reason being is that the antibody classes, so you have mentioned LGI also. So the LGI is IgG4
Yes.
and the others are IgG1, 2 and 3.
Yes.
So the injury to the hippocampus is much more because they can activate the complement cascade. So you should be very aggressive for NMDA. And the hippocampal sclerosis as a endpoint and the secondary epilepsy can be triggered. So that is, you have to be very aggressive for NMDA. LGI1 may not have that much of hippocampal sclerosis as a follow-up.
Sure, sir.
Just one more point. Serum may pick up in majority, but 5 to 10% may be missed. So in high suspicion, CSF should be checked for the autoimmune panels and NMD antibody. Yeah.
Yes, ma'am. So that was my next question. Our residents always say, we are in a resource-constrained hospital. Madam, should I send CSF or should I send serum for the panel? So as ma'am has already said that CSF is preferred because we understand that the antibodies are often produced intrathecally and CSF titers correlate better with the disease activity. Serum alone may give some false positives. And if resource constrained, then CSF sample should be sent specially for NMDA. Shekhar sir, can you tell us how soon the steroid should be started? Should one wait for report? This patient has come to me in the emergency. My resident thinks that it is NMDA, but he's scared. Like, should I send the report, then start the steroids? Or what should I do? And what are the other treatment modalities?
So because this is a treatable condition and can have long-term devastating outcome, I think the moment the thought comes to your mind, you should start the treatment regardless of whether you have sent off the test or no. So you should be starting steroids as early as possible. The other treatment modalities, yes, IV immunoglobulins, rituximab, and plasma exchange if it is feasible, because for a pediatric setup that becomes slightly tricky, but for the adult world, a plasma exchange is preferred over the other modalities, especially NMDA. Cyclophosphamide, yes, for refractory cases, you can definitely.
Yes. So even can empirical therapy be started if we are unable to send? There is
Yes.
no money available. So can we start empirical therapy? Yes.
Because you do have antibody negative autoimmunism. So you if you're strongly suspecting, you should offer the treatment.
Sure. So clinical suspicion and the clinician's call is the most important in this. So here again, what do we learn? Behavioral changes, extremely important. They may precede neurological signs by weeks. So definitely this child can go to a general pediatrician, okay, with behavioral changes. CSF is more sensitive, especially for NMDA antibodies. In a resource-limited setting, start empirical treatment even without antibodies testing.
As compared to an older child, and you have poly symptoms even at the presentation when the child is younger.
Yes, sir.
That's that point.
Yes.
I just because the symptomatology in autoimmune in younger age is different than the adolescent. And
Typically, adolescent
Yeah.
females, they come with more psychiatric
Yeah.
presentation, while below 10 years, it is more seizures and movement disorder, which are preferred treatment.
And one more issue in our country, if I don't know what is the exact incidence of herpes, but post-herpetic NMDR is also a very well-known entity.
Any infection
Yeah.
can
That will expose the neural
because of
antigen to the
inflammation of
antibody. Yes, yes.
brain.
Yeah,
It gets exposed to antibody to antigens are exposed, so antibody production is triggered. So typically HSV, around 30% of HSV have antibodies to NMDA, out of which 5% can actually present like an NMDR encephalitis post herpes.
And regarding the empirical, I think if you have a possible clinical setting for autoimmune encephalitis, even antibody negative can be started on
Yes,
treatment.
yes. As Shekhar sir already mentioned that, you know, in many cases the
Yeah.
antibody is negative.
Because by the way, you are doing MRI, you have ruled out the mimics of autoimmune encephalitis, most of the mimics.
So an MRI normal gives us a clinch and point well taken. Thank you so much, sir. Coming to our last case, this is a 4-year-old boy. He was born of non-consanguineous marriage, normal birth and development. He had fever for 4 days, followed by one episode of just left clonic seizure lasting for 2 minutes, after which the child became drowsy. On day 7 of illness, the mother said that he had left focal status epilepticus. Followed by this, there was left hemiparesis, but this was not associated with any cranial nerve palsy. And on day 10 of illness, he developed right hemiparesis, and this was followed by encephalopathy. There was no history of any sensory involvement, no history of any bladder bowel involvement, no history of any recent vaccination. So examination findings for residents, since the child is having bilateral hemiparesis, hence we asked for bladder bowel complaints since we localize it to the spine. So on examination, the child was encephalopathic, had reduced responsiveness, GCS was 10/15. His cranial nerves were perfectly normal. Motor-wise, there was hypotonia in all 4 limbs. Power on the left side was 2/5, whereas on the right was 3/5. He just had brisk deep tendon reflexes, whereas the plantars were normal. Sensory system, there was no band of hyperalgesia present. So to summarize, a 4-year-old boy, again this child had subacute onset of encephalopathy with fever, left focal status epilepticus. He had multifocal signs, just left followed by right hemiparesis, but this was not having cranial nerve involvement. For residents, it's extremely important to know that whenever the child is having hemiparesis or stroke, to note whether cranial nerve involvement is present or not. No sensory or bladder bowel involvement. So what would be the differential diagnosis? Whether it is a subacute febrile encephalopathy because the child had fever, he's encephalopathic and some seizures which are just causing some amount of hemiparesis. Whether he is a case of acute demyelinating encephalomyelitis or whether he is a case of myelin oligodendrocyte associated disease. So we did the further investigations. A CSF was done. It showed 150 cells, which was lymphocytic predominance, and CSF culture was no growth. EEG was done again because the child had seizures. It was diffuse slowing, no particular epileptiform discharges. Since we have already localized, that there was bilateral hemiparesis and there is encephalopathy, so it could be the spine as well as the brain both involved. So we did an MRI, and if you can see on the right-hand side in the MRI brain over here, there is just a T2 flare hyperintense signal in juxtacortical and subcortical white matter. And if you can see over here in the spine, in the sagittal of the spine, there is a non-enhancing signal intensity in the cervicodorsal spinal cord. So we sent the MOG antibodies and the MOG IgG came positive, and hence the diagnosis of myelin oligodendrocyte glycoprotein antibody associated disease was given. Again here, a child was given IV methylprednisolone 30 milligram per kg pulse for 5 days, followed by oral prednisolone. Levetiracetam was given for the seizures that he had. Dramatic response, sensorium improved by day 4 of steroids. Motor recovery began by day 6. His left-sided weakness improved to 4/5. Right side became completely normalized, and there was no further seizures. So, Mona ma'am, can you tell us what is the hallmark feature of ADEM?
So, as you put it up in this patient also, so you can have encephalopathic is the primary presentation in the ADEM, and acute dramatic encephalopathy which is there is no infection, no fever, and child could have focal neurological deficits. They can present even with just transverse myelitis signs with bladder bowel involvement, etc., and paresis which is seen. So these are a few of the things that we usually see with an ADEM kind of a presentation.
Yes, ma'am. So over here also in our child, there was fever, but fever was not that high to explain anything, but there was more encephalopathy rather than fever, and it was multifocal, left followed by right, and MRI definitely showed us demyelination. Shekhar sir, can you tell us how do we clinically differentiate in between MOG, NMO, and MS, and just what are these?
So all are demyelinating conditions, but the outcome is different for him. So MOG antibody disease basically will be like an acute illness with the features similar to, let's say, of your typical ADEM. NMO, you will have various syndromes specific, but then they will have unilateral optic neuritis, and the MS1 will have the bilateral optic neuritis, and you have MRI features to go by. MS will be more of a relapsing disease, but you can actually have the first clinical presentation, and you can look at your MRI criteria whether you have evidence of old demyelinating lesions. The contrast scan helps us to do differentiate between acute and chronic lesions. The site of the demyelination also helps us differentiate between NMO, MOGAD, and the MS. So if you look at the NMO picture, you will have long demyelinating lesions in the spine, even with the MOGAD, and MS you will actually have a shorter segments. The treatment options is different in terms of female preponderance. Then you will have a variation between MOGAD as well as NMO and MS, and the treatment options for MOG will be steroids. For NMO, you would actually consider rituximab and other immunomodulatory therapies. The outcome, even after appreciation of the diagnosis, adequate treatment, your outcome may not be necessarily good. With MS, now we have a lot of other biologics which are available, and right now looking at ocrelizumab, it actually is promoting good results. You can actually consider, depending on how you actually go about with the costing. So first episode, you will always treat with IV steroids, and subsequently you can move to one of the biologics. So because the newer ones are available, earlier we used to use rituximab even for MS, but now with the advent of the newer ones, we are shifting from rituximab to the newer one. Alemtuzumab is other one which promises that within 2 years you will be what we call as NEDA, that is no evidence of disease activity. So that's the end point that you actually look for with the MS.
Sure. Thank you so much, sir, for that elaborative and precise answer. As you said that, this is very much MRI-based diagnosis. So Neelu ma'am, can you just highlight for the sake of residents and pediatricians that what would be the MRI findings in MOG, NMO and MS, how they are different?
So yeah, clinically, as Shekhar said, they may all look same. The first attack, typically younger children, MOG is much more common, NMO and MS, female predominant NMO. And MRI wise, as Shekhar also mentioned, long segment typically seen both in MOG and NMO, while short segment in MS. Bilateral, more in MOG NMO, unilateral, more in MS. Dawson's fingers, actually MS is very rare in children, so generally what we see more common is MOG and NMO, and MOG in your seronegative autoimmune encephalitis also MOG often is one of the differentials. If MRI is showing abnormality, like in NMDA when we last case we did, it's an overlap, and of course MRI would be abnormal in MOG, unlike in NMDA, but the typical features are anteriorly more optic nerve involvement is typically seen in MOG, while posteriorly and chiasm is more in NMO. MS again short segment and unilateral.
Thank you so much. So yes, we just finished the panel. Learning points for residents here. Multifocal CNS signs are a key to widespread demyelination, something that you're not able to localize or it's just unfolding. MRI brain with screening of the spine or with the whole spine is extremely important, because we do get cases from outside where only MRI brain is done and spine has not been done, and the child has already received steroids, so the signal may not be there. So MRI brain with spine should be the first line of investigation in all suspected cases of demyelinating disorders. Yes, again, as this is a treatable disorder, and if you hit it hard, sooner the treatment, better the recovery. So empirical treatment with steroids should be given even before laboratory confirmation in suspected cases of MOGAD. And early treatment prevents the risk recurrence. Some of these disorders, especially MOGAD, can recur later. So early treatment would definitely prevent the risk recurrence. So I would like to acknowledge our head of the department, Dr. Radha Gildial ma'am, for giving us this opportunity, our esteemed panelists, and of course our neurology fellows, Dr. Nitin and Dr. Aditi, for their contribution. So every child we heal is not just a patient, but a promise kept to the future. Thank you so much all for your patient hearing.
Thank you so much for this extremely insightful discussion. May I now request Dr. Sadhna Zope to present our moderator and the panelists with a token of our appreciation. Adolescent behavior embodies the complex dynamics of biological maturation and social experimentation. This period is marked by curiosity, contradictions, and emotional turbulence. The following session will surely help us to decipher these complex behavioral patterns. I would like to invite our chairpersons on the stage, Dr. Madhuri Kulkarni and Dr. Mamta Manglani. Dr. Madhuri Kulkarni has been the former Dean, Head of Department Pediatrics and in charge of the Learning Disability Clinic at LTMGH. Dr. Mamta Manglani has been the Founder Director of the Comprehensive Thalassemia Care, Pediatric Hematology Oncology and BMT Center at Borivali and is currently the Director of the Pediatric Hemat-Oncology and BMT Center at the Sanac Cancer Institute, Khar. I would request our chairpersons to kindly introduce the speaker for this session, Dr. Sameer Dalwai.
Good afternoon, namaskar. It's a great pleasure to be here in Sion Hospital to attend this DAFPAL conference annual event, which we all look forward to. And today we are all here to have the participation in this program. And I'm so happy that I could see so many of my teachers, colleagues, students, all are here. Thank you so much, Department of Pediatrics, Radha and her team for inviting us here for this program. It's a great pleasure to introduce Sameer. Sameer is like student to all of us because though he is from JJ Hospital, we always had interaction with him in Sion and at so many conferences. We always look forward to your talks. They are so impressive, so elaborative, and very, very informative. So I'm sure today's talk also is going to be like that. I have heard and seen so many of your videos informing parents, guiding parents for behavior, how to handle and how to prevent behavioral problems in children. Dr. Sameer needs no introduction to this audience, but just as a formality, I'm going to read. He's a developmental behavioral pediatrician. He has his own clinic, which has got a lot of branches in Mumbai, and I don't know whether it is outside Mumbai also now. Ahena? Yes. Okay. He was treasurer and joint secretary for EBCIAP, Central IAP, and IAP Mumbai. He was president during 2016-2017. Sameer? Yes, yes, I think it is already there. Okay. He will be discussing about decoding the teenage mind, adolescent behavioral patterns. Sameer, please.
Namaskar, respected chairpersons, both of whom are like elders, mothers to me, Dr. Madhuri ma'am, Dr. Mamta ma'am, all my respected seniors. I will not take names, but Dr. Radha ma'am, thanks for the opportunity. And very rarely I'm nervous before a presentation, but today I am because all of you are my teachers here. Today, you've heard just now about MS, NMO, MOGAD, and I wanted to say, oh my God. And after all what sounded like a science fiction channel, what I'm going to talk about might actually sound like Astha channel. What I'm going to talk about is basically of two parts. One is I'm going to talk about a case and then some observations about adolescent medicine. What I would like to say at the beginning is, as a disclaimer, just like a child is born agnostic of the world, he or she doesn't know anything. We give the child a name, a religion, a caste, a gender appropriate behavior, a social appropriate behavior, a culture, and then that child becomes locked in that compartment. Don't you all feel that yourself? When we are dealing with a subject of adolescence and as a larger part of mental health, where there is very little to do all those CSF and send for that MOGAD antibodies, where there is nothing substantial or material that you can hold on, it's largely up in the air. And when there is no substance, then this name, caste, religion, region becomes even more stronger. And that is what is happening in this field of adolescence. It's just a normal part of life. But we as specialists, to make ourselves special, have cast it into an iron compartment. And now we have some terms that we try to apply to them all the time, instead of looking at it just as a part of life and how beautiful that can be. So I'll begin with a case and then we'll go back to this part which I said earlier, how all of us can help adolescents. We don't have to be adolescent specialists. So this 18-year-old child was brought with a refusal to attend college. He had no friends, he was withdrawn. He was referred by my dear friend Dr. Anand Kumta. Some of you might know him as an eminent ophthalmologist and son of Dr. N.B. Kumta. So this sister, the sister who worked in his hospital, it was her son. Normal developmental milestones, maternal uncle had history of epilepsy, and his interaction, which I always like to see, was good with peers. The story began at 11 years where mother reported that he started being very isolated and he had academic problems. They did an evaluation typically and it typically showed high IQ, the result the report of which has nothing to do different from before you receive the report, and some kind of remedial education done for 2 months. The key issue was that he spent about 10 hours per day on screen time, on watching reels or making reels or on Instagram or on video games or gambling and things like that. So we call it a gaming addiction with parenting dysfunction. So what did we want to work on? The child would not even initially want to come to the clinic for any course. So just to begin with, sharing with you what we did in the clinic. So increasing, the first thing we try to focus on is get the child to engage more with the parents. So increase the engagement level. Now you see, I'm not talking about stopping screen time. The first thing all of you would have said, stop his screen time. 10 hours per day, it's the worst part of his life. All of us know that, but we are never able to change it. And that is because we are hitting the symptom. The digital time and the screen time is only the trigger. It is the altered social environment which is a loaded gun, and the screen time is only the trigger that we pull. So unless we change the background, so the first thing, what we worked on with this child had helped, increasing engagement. All of us want my child to be more confident. My child doesn't talk to me confidently. It's not about confidence, it's about trust. People talk to you when they have trust, and they have confidence when they have trust. So how do you enable trust? By stopping the parents from criticizing the child for everything. And then ensure that the parents model healthy screen behavior themselves and encourage parents to take an active role. By active, I have highlighted the word active. Active means physically doing something. Get out of the house. Go to an uncle's house, go to a relative's house, go to a cinema theater, go to a playground, go to Juhu Beach, go somewhere. Do some physical activity yourself. And then come to the child. Then give gyan to the child. Give a structured routine, and in that routine, all of us talk about set clear boundaries. Nobody knows what it means. Basically, it's a reward and punishment or a reward and reprimand system in which, please remember, give and take is very important. The give always comes before take in this English phrase. That's why unless parents are able to give something to the child, they are unable to expect something back from the child. After doing this, then come to the final symptom of screen time and supervision of content. And then, of course, open discussion, making the parents and child understand what else they can do besides watching screen time. So nowhere have I said stop the screen time. Everywhere you have said do 10 other things that can be done, which will be an alternative to screen time. So basic, the terms like positive reinforcement, we all know rewarding positive behavior works. helping parents understand this, because most parents do not understand how severe and difficult, how dangerous the screen time is. Parents always tell me कि आप बच्चे को बोलो टीवी मत देखो. I tell them, बच्चा बोलेगा मेरे फादर का टीवी है, तुम कौन है बोलने वाला, मत देखो. That's a reality, which means the person who owns that has to tell them not to do it. And the second point is, I asked, बच्चा टीवी के लिए बहुत रोता है, smaller children. So, अल्कोहल के लिए रोएगा तो पिलाएगा, सिगरेट मांगेगा रोके तो देगा, नहीं वो कैसे देंगे? Which means or proves that they don't think excessive screen time is anywhere as dangerous as alcohol. So that is where helping parents understand comes in, and of course providing strategies, as we said. But the key issue for a long-term improvement is strengthening parent-child relationship by promoting quality family time and bonding over other interests outside of digital games and academics. Because the maximum bonding that happens between the mother and child today is over homework and schoolwork and projects and completing. All the ladies, mothers are giggling here, which they know it's a kind of guilt may be there. But academics is probably the reason which breaks down all kind of relationships, because then you're not focusing on each other, you're focusing on the syllabus, not on each other. And hence helping parents create a supportive environment where children feel valued beyond their gaming achievements. So all this key issue that we have realized in our work is, don't focus on that isolated symptom of screen time. Look at the sequence of events. This child was going along fine. He had a grandmother who was at home. The mother was, as I said, working in Dr. Anand's clinic, and father was doing his own job. And he had a great time with the grandmother, who was very bubbly and joyous and doing 100 things. And then she unfortunately had an illness and she passed away. And after this, the parents thought, okay, now he's gone big enough. Now he'll be going to school and classes. They didn't realize that the classes cannot substitute the vivacity and the exchange engagement of a grandmother. And this was the beginning of the whole thing. So no point taking history, screen time, right se screen dekhta hai, ki left se dekhta hai, upar se dekhta hai, all that is ridiculous. The real story is behind. That's when the story began. And hence also ruling out underlying causes. I cannot tell you how many children get referred to us for screen time addiction or toileting issues, when the actual problem is a social engagement issue of autism or hyperactivity. So addressing these unresolved childhood issues, like for example, the child was abandoned somewhere, he got lost in a fair or in some mall somewhere, and for 4 or 5 hours the parents were searching. How many of you are aware that at Juhu Beach, every day about 5 to 10 children get lost on the weekend, on the crowded days? And there are some friends of mine whose only job is to try and locate that child and get them back to the parent. Each such episode could have left a fright in the mind of the child, which is never ever talked about. Because what is the first thing that happens when the child is rescued and taken to the mother and father? They are waiting at that Juhu police station. Yes, Upendra, what is the first thing that happens? Do झापड़ किधर घूमने गया था? हरवला असता तर सासूबाईने माझी वाट लावली असती घरी, कळलं नाही का तुला? All this happens. He said, अरे घूम गया होता तो better होता. And we talk about empathy and patience, etc. And all these statements, adolescence is a transition, focus on guidance, not control. Simple. Focus on guidance, not control. In which case, why would there be so many children with failures, so many children with anxiety, depression, suicide? Problem would have been solved. And that's because if you look at what has come out of the United States, which is the forefather of all mental health treatment, which is so ridiculous, is that this is the Wall Street Journal report, which said children as young as 4 are started on multiple psychiatric medications, when the reality is many have experienced adversity or trauma and have behavioral problems as a result that get labeled as ADHD. And then you can see that quickly diagnosed and prescribed medication, and that doesn't tackle the root cause. And my life journey has been the developmental behavioral subject of pediatrics and adolescents. Don't look at the symptoms, but that's what the Americans look for, and then that's what it is. Look at this graph. Children who were prescribed ADHD drugs in 2019, by the time it was 2023, look at the number of children who were on multiple drugs. 23% were on more than 2 drugs, 8.6% on more than 3 drugs, and 2.6% on more than 4 drugs, just in a matter of 5 to 6 years, which means that the medication and the profit gained by pharma companies has increased. Children's problem have not been solved. Whereas those prescribed later, only a year or 2 later, see the number of medications are much lesser. And what is one of the reasons? One of the reasons is mental health. We all have this propensity for tools, 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 tools. If you say it very fast, it sounds like stools, which I believe sometimes it is equivalent intellectually too. This is how it is. We are all fond of filling up these forms. And guess what? Even the doctors who are rating you and diagnosing you, Surbhi ma'am, are only filling up forms. And when you ask the parent, does your child do this, do this, do this? 6 out of 9, Priyanka, you have ADHD. You are only scoring symptoms. It's like saying if you have 104-degree fever and 3 chills a day, you have malaria. But if you have 102-degree fever and only 1 chill a day, you don't have malaria. But guess what? Both are still treated by giving paracetamol. So this is the key issue that we must understand, and now looking at what exactly is adolescence. It's not a new beginning, because the beginning starts when you're conceived, because that's when the neurons start. And we know that the first 1,000 days is maximum neuroplasticity, but it never really stops. The stimulation stops. The brain doesn't stop learning. But if there isn't enough stimulation, your brain will not develop these new synapses. And if we understand the child, we will never be surprised by the adolescent. So for God's sake, don't break it up into a compartment. 10 to 18, 10 to 18, 10 to 18. ऐसा कुछ नहीं है. ऐसा कुछ नहीं है. It's an artificial speciality developed by some physicians. It's a continuum. And hence, that continuum is also going to go ahead. And this is transgenerational. Because what you see, that man on the right, he is going to impact his grandchild as well. And hence it's all one big circle, it's not a linear curve. At New Horizons, when we worked with autism, etc., one thing which I want to share is, even social communication development or social behavior and communication development is a sequence. Why is it a sequence? Like head holding, rolling over, sitting, standing, walking are gross motor milestones and sequence. The sequence starts with human engagement at birth. When the child starts noticing the mother and observing the mother, he soon learns that when the bell rings, the mother goes and opens the door. And when the bell doesn't ring, the mother doesn't go and open the door. This is behavior. Therapists teach us gross motor, fine motor, gross motor, fine. How to open the door. That's not behavior. What you see is not behavior. Understanding what to do with someone and what not to do with someone. किसके साथ क्या करने का है, किसके साथ वो चीज़ नहीं करने का. मम्मी अभी अच्छे मूड में है, कुछ भी करो. अब डैडी गुस्से में 2 लगा देंगे, अभी नहीं करने का कुछ. That is behavior. And that can only be understood by observing people in a normal situation. If the child understands when to open the door, when not to open the door, he or she understands when to carry the plates, when to bring the water, where to change clothes, where not to change clothes, how to do your daily activities, etc., etc. And thereafter comes non-verbal communication and verbal communication and reading and writing finally. Unfortunately, all of us are obsessed with reading and writing, and because school admissions require speech, that's why parents are obsessed with speech. Nobody cares before that whether the milestones of human engagement, human behavior and non-verbal communication have been learnt or no. But if you ever read the masters like Osho and the Indian philosophy, speech was overrated. All our great Upanishads and Vedas all said that it is language which gives you too much of division, and takes you away from your environment. The more you think, the more you lose touch with reality. The quieter you are, the more connected you are to the sea, you are more connected to the trees, more connected to the environment around you. And connection comes from being, but it is speech and too much of knowledge that actually breaks it down. Again, the same thing. Adolescence, this is my knowledge. Every child who comes to my clinic, I will see him with these tools. That is exactly the problem. But the social ecology of adolescence is the teen's behavior is a reflection of what he has learnt at home, school, peer groups and culture, and not in adolescent classes or any IAP module or not in any New Horizon Developmental Center ke therapy classes. And hence community matters as much as the neurobiology. I would say matters more, because you cannot change the neurobiology, you cannot change the genes, but you can change how you approach the child. And if you have to read one person in psychology, please read Lev Vygotsky. I put his name there. The guy, the yellow. Please read Lev Vygotsky, because he said a child learns by those closest to him, develops then has the ability to learn from somebody a little further away, develops, then has the ability to connect to somebody further. So the child first learns from the mother and the father, then from the chachi, masi, bua, mami, because they are closest to the mother, and then from chulat chachi, nan kaki, hi maushi, ti maushi, then shezarchi kaku, who are not even related to you, and you may be a Kulkarni, the shezarchi kaku may be a Pille, or a Shah, or a Patel, or a Gonsalves, and then your brain has developed enough to deal with people, so you can go to a classroom full of 50, 60 children who are very different, and you are able to learn and adapt with them. So all these things, dear friends, are far more important in adolescence than any tool or any medication that you have. But unfortunately, gradually, if you see the previous pictures, which is only and only family engaging with each other, human engagement, gradually gets transferred towards blocks, then pegs, then red color, blue color, pencil, matching, shape sorting, drawing within the circles, and ending up eventually with, you don't even need a human being when you have a machine like a laptop or a computer. And hence the road to academics is full of perdition. Do not rush for academics before your child has mastered social engagement. And this is exactly what we learned at New Horizons, that parental coaching is far more important than actually treating the adolescent with any medications or counseling or therapy. So maybe about 3 minutes, I'll just try to clear some myths. For example, behavior is communication, not defiance. No, behavior is a response, often unintended, which we mark, oh, he is hyperactive. Mood swings are, children with adolescents have mood swings. What do you do about it? Oh, accept it. It's not true. Understand that there is sometimes a normal response of a person who does not know how to deal with the situation. If you are faced with this, you are happy, somebody comes and tells you something happened just now, which is a problem, suddenly what is going to happen to you? Yeah, you call it a mood swing? No, it's a normal response when you do not know what to do with the situation. You want to do something but cannot, and you are being judged. Oh, look at this fellow, he's always like this. This is the atmosphere we are subjecting the adolescents to, and we are calling it mood swings. Risk-taking, adolescent brain, autonomy, seeking autonomy, rebellion. Kuch nahi hai. The child who just found out that he has failed, and when he goes home, the father sees the report card is going to beat him up, is bound to say कि boss report आया ही नहीं, अभी 2 दिन के बाद आने वाला है. Or he's going to probably sign something else. He's going to, is that risk-taking behavior? Of course it is risk-taking. He's trying to save getting beaten up. Who won't do that? It is not to be blamed on the adolescent biochemistry of the brain. It is the situation. Because the biochemistry you cannot change with all these medications. You can change the situation. And similarly, this child is withdrawn, like my case was. This child is now withdrawn. It's basically nothing but he's rational enough to stay quiet, guarded, weighing his options, until a safe, trusted hand or help appears. So I don't want to go on to this because I thought a lot of these things to say. But for example, identity formation. Who am I? Dominates every action. That is what every American textbook will tell you. An adolescent is trying to find out, who am I? Rubbish. He is trying to find what will happen next. Abhi mere kam mark aayenge, to abhi kya hone wala hai? He is not trying to find out, who am I? I am Changiz Khan. It doesn't matter, dad, whether I score less marks. He is not thinking like that. He says, abhi kya hoga next? Pitne wala hu ya kuch sunne wala hu? And these are the things, the point that I want to say. For example, mental health flags, sudden drop in functioning. What is a sudden drop in functioning? I have seen enough children who dropped gradually, slowly, insidiously. Don't keep only watching for a sudden drop. Persistent irritability. What is persistent irritability? But irritability with previously formed situations. Previously the child liked to sit and talk with the grandmother. Now he doesn't want to. These things are very important, and not just changes in sleep or appetite, changes in anything. Even the choice of language, the friendship that the child has, and risk-taking with intent rather than curiosity. American jargon. Reality, social withdrawal in previously formed situations. So I'm going to conclude by saying 1 or 2 things more. What is a pediatrician's role? The Americans say, be the translator between teen and parent. Matlab, you are trying to tell the parent what the child wants, and you try to tell the child what the parent wants. Both of them will hate you. What you want to do is don't get lost in translation, na idhar na udhar. Normalizing the chaos, highlight the strengths. Rather than that, teach deep breathing techniques. That will help the mother and father more. And bring up some good stuff. You know, there is a lovely movie, and that song we'll remember, Wo Jo Albela Hazaron Mein Akela, etc., etc. So look at every child's good points. And what I would like to conclude is, as pediatricians, we must mandate teaching parents the importance of engaging with their families and friends and to find joy in human engagement. And this is what parents must be explained, that this is the new normal and this is how you'll have to go back. I'll just play one video because this probably captures the essence of what I feel.
अगर आप चाहते हैं कि आपके पीछे आपका बच्चा सक्सेसफुल हो, वो उसके कर्मों से नहीं होता. Not only his ability but the ability of the world to tolerate him and support him. कोई भी महारथी अपने आप से महारथी नहीं बना. You need world to support you. आप बच्चे को इतना इस सोसाइटी में ले जाओ कि वो कल इलेक्शन चुन के आए. अब ये क्या होता है, कौन इलेक्शन चुन के आता है?
I did not learn
एक
this.
बंदे से मिले तो उसकी तारीफ करे, दूसरे से मिले इसको उल्टा. अभी ये बहुत नेगेटिव चीज तक जाती है, ये छोड़ दो. मगर डिप्लोमेसी तो यही बात है ना, जो उस सिचुएशन को देख के हैंडल कर सकता है. अगर आपका बच्चा लोगों को हैंडल कर सकता है, ही इज अ परफेक्टली नॉर्मल चाइल्ड एंड ही हैज फुल चांस ऑफ बीइंग सक्सेसफुल. अब रह गया कि कौन से फील्ड में काम कर रहा है. इट्स ओके, डजंट मैटर. कोई डॉक्टर है, कोई इंजीनियर है, कोई स्टॉक ब्रोकर है, कोई लॉयर है, बट इन ऑल ऑफ देम द कॉमन थिंग इज एबिलिटी टू डील विद पीपल एंड टू शो रेजिलियंस. अगर आप चाहते हैं कि आपके स्पेशल चिल्ड्रन के पेरेंट्स को हम सिखाते हैं, सबसे जरूरी चीज है दैट योर चाइल्ड शुड बी एबल टू स्पेंड 2 days विद चाची, मासी, बुआ, मामी विदाउट यू इन देयर हाउस, डूइंग व्हाट चाची वांट्स इन चाचीज हाउस एंड डूइंग व्हाट मासी वांट्स इन मासीज हाउस. फॉर मी a child who is able to do this is a normal child. मासी बोलते अरे ठीक है, अच्छा है, लेकिन फिर और भेज दे 2 दिन के लिए. She is welcoming him back because he is adjusting to her. He knows मासी को कैसे हैंडल करना है. मासी's house is welcome. This means that this child is normal. Why I am saying? Because now we can survive without the mother and father. If something happens to the mother and father, eventually will happen. This child can stay with the rest of society and the rest of society is happy to keep him with them. Then आपको वो इंश्योरेंस हो गया कि मैं नहीं भी हूँ तो मेरा बच्चे को सोसाइटी संभाल लेगी. स्पेशल चिल्ड्रन.
So I just wanted you to take a picture of this so that you can access hundreds of such videos out there, and it's all free. And you can just do a scan that QR code and you can get there. And these are all the QR codes. You can find all these videos. You can share it with your patients, with your friends, your neighbors. And I'll just give, and this is one video, QR code which I'd like you to see. There's an article on how the social structure is now changing and harming our children. It's not abnormal genes or bad genes only, and how simple hug can matter from preventing a child from disaster. Finally, I'd like to close with this picture. All of you know who this man, great man is, and the song is? So as a pediatrician, whenever I get a labor call, I am hoping कि बच्चा रोते हुए आए. But once I reach there and he's crying, then it's the job of the pediatrician to make sure that the child does not cry for the rest of the life and keeps laughing. Thank you very much.
Thank you, Sameer. I think you wonderfully put across these thoughts to us, and now we are also wondering family engagement, so we should finish the CME soon. And also one message to all the mothers who have adolescent children or likely to have soon adolescent children, keep your mothers-in-law happy so that they have a grandmother at home, so that the same issues don't come. Wonderful. Thank you, Sameer, for a wonderful and enlightening talk. Always a pleasure to hear you.
Thank you. Thank you so much. Thanks a lot. Sorry.
Thank you, sir, for this fascinating discussion. I would request our chairpersons to present our speaker with a token. Hello. I now request Dr. Sadhna Sope to present the chairperson with a token of our appreciation. Thank you all. As we continue with today's scientific sessions, we now bring to you the Gut Intelligence Quiz, where knowledge meets intuition and the smartest guts win. This quiz will challenge your clinical instincts and test your gastroenterology and hepatology knowledge. Get ready for exciting questions in a fun and competitive spirit. May the best gut win. May I call upon our quiz master for today. Dr. Prachi Karnik is an additional associate professor, Department of Pediatrics, LTMGH. And she is also the in charge, Division of Pediatric Gastroenterology and Hepatology at LTMGH. Welcome, ma'am.
Thank you, Aditi. So as we come to this quiz at the outset, I would like to put on record that two of my colleagues, Dr. Aditi Dharap, who was a lecturer with us in gastroenterology just till recently, has helped me with the quiz to prepare the first draft of the quiz. And my fellow, Dr. Rutuja Badge, who's on stage with me, has been the entire technical support for this. We have already put up all the rules for the quiz on the group, and we have put up the QR code as well and a link. So all of you, those who have not yet done, can still go to kahoot.it. It's not in, it's it. And once you go there, you will be able to, have to enter this game pin, or you can also scan the QR code that is given there. While you all are doing that, Dr. Rutusha will tell you the rules of the quiz once more quickly. And we request you all to put your full names, please, so that there is no challenge in deciding who's the winner in case you all are sharing your initials. We have 3 prizes also at the end of the quiz. Rutusha, can you tell them the rules?
Yes. So, welcome to our gut intelligence quiz. First of all, please take out your phones or tablets and go to kahoot.in. You can access the link via the link which is provided in the WhatsApp group. You will see the question on the main screen and the answer options on your device. You have to tap the shape or color that matches your option. There will be 15 questions. 30 seconds will be given for each question. Speed and accuracy
There's one
matters.
group of delegates,
Kahoot
or you can
rewards
just
you.
scan it right now, ma'am.
Kahoot rewards you for answering correctly and quickly. Faster answers get more points. Once you tap your answer, it is locked in. There is no negative marking, but no changing your answers either. Make sure your internet is stable. However, if you disconnect, you can rejoin anytime using the same game pin and the leaderboard updates. After every question, you will see a leaderboard podium displaying the top 5 participants, and at the end, we will announce the top 3 performers. The winners will be given exciting prizes. I will just show you a demo quiz so that you have a better understanding.
Rutuja, I think just wait for the demo. Some people are still trying to log in. We'll just wait for 2 minutes. Ma'am, anyone needs help, we'll come down and help you.
Currently, 53 participants have joined.
You can just go to Google and type kahoot.it, and you will be directed to the website. Sanya, just help ma'am, no? No, Mangalani ma'am. So while we start, I'll again quickly tell you what we're going to do. There are going to be 15 questions here. The timer starts as soon as I start reading the question. So I'll take about 15 or 20 seconds to read. You will get 10 to 15 seconds to answer. Okay? You will be able to see the options on this screen, and on your phones you will have to select the color that matches the color of the answer. The right answer will get the marks, but if there are many people who have given the right answer, the one who has done it fastest will get more marks. So that is how the app itself will calculate the marks. There's nothing in our hands. So we'll show you a small demo with 2 or 3 questions.
So for the demo quiz, I'll enter the pin as shown.
This is a demo, you all don't have to enter this. Look at this screen, this is what you all are going to do.
So this is how the question will appear.
So you all will be seeing the main question first because that's the format in the thing, and the detail of the case will come later. This will be the 4 options, and what you will see on your mobile is this screen. You will just see the red, blue, yellow, green color. So deciding upon the correct answer there, you have to mark accordingly on your screens. And then the first 5 top, the people who get the top 5 marks will be displayed on the screen at the end of every question.
This is the second question. 30 seconds will be allotted for each question. For example, if you want to answer option 3, which is autoimmune sclerosing cholangitis, then you'll have to tap on yellow colored, which corresponds to 0 figure, circle. And it will show whether it is correct and how many people have answered correctly. Should I start?
Yeah, so the idea of this is, of course, to have a fun quiz, but also to give you all some takeaway points, 1 or 2 takeaway points per question. And then we go on to the next. So shall we start? All of you are ready?
62 participants have logged in.
You all can join in between also in case somebody walks in, your friends, neighbors, you can tell them to join in. The marks will, of course, may not match, but that's fine. Yeah.
So I'm starting.
So this is a 12-year-old girl who came with recurrent hepatitis since 7 years of age. Along with jaundice and firm hepatosplenomegaly, she also had some thyroid swelling. The bilirubin was high, AST, LT, there was transaminitis, low albumin, and the TSH was elevated with a free T3, T4 low. Which set of investigations would you prefer to do first? So the correct answer was ANA, ASMA and anti-LKM along with total IgG. Most of you have answered it correctly. It was a simple case of autoimmune hepatitis. The takeaway point here, there are 2 things. One is that whenever you have a multi-system disorder or an autoimmune kind of picture, always look for other systems. We have ourselves seen many patients who came as alopecia areata and then some mild derangement of LFT, they turned out to be autoimmune hepatitis. Many of our type 1 diabetes, many of our IBDs have an associated autoimmune hepatitis. So, and thyroiditis, of course. Other than that, what we have written here is total IgG. So many of these patients of AIH, they may not have a anti-LKM elevated or an ASMA elevated, but a total IgG high will give you a clue towards an autoimmune hepatitis, and you can start treatment just based on that. So always order for total IgG along with the rest of the panel. Next question. So this is a 10-year-old girl, known case of type 1 diabetes, and she went to the nutrition OPD for refractory anemia, referred to us, had pallor, stunting, abdomen was mildly distended, and these were her upper GI endoscopy findings. I'll describe them to you. You're seeing some fissuring, and you're seeing scalloping of the edema. The wavy pattern of the mucosa is scalloping. So which investigation should be ordered next? So yes, most of the people again had answered correctly. The takeaway point here is that do not ever order only the TTG IgA, always with the total IgA, because in a case of IgA deficiency, you may falsely get the total IgA low. Some of you, I think, had answered EMA also. The thing is, EMA is highly specific, but many times can have a lot of false positives. So always go by the TTG IgA first and then the biopsy. Next question. This was a 20-day-old full-term infant, non-consanguineous marriage, jaundice since day of life 15. He was well-grown, non-sick. These were the stools that were present, had a firm hepatomegaly, which should be the investigation to confirm the diagnosis. Yes, so we have a lot of people still saying HIDA scan and an abdominal USG. Those who said abdominal USG may not be entirely wrong, but our question was for confirming the diagnosis. So USG will never give you a confirmed diagnosis. And this is why we put up this question. We want the takeaway point that HIDA is not really a good, any more recommended test for this. Because even if your HIDA is non-excretory, it could be things other than biliary atresia also. And for doing the HIDA, you have to give 5 days of phenobarbital. After that, you have to do the HIDA. Then the 24-hour scan, you're wasting a whole week. And every day wasted is a poor outcome for a biliary atresia child. So liver biopsy from a good histopathologist with the result available in 2-3 days is the gold standard that is currently to be practiced. Next. A 10-year-old girl who came with severe epigastric abdominal pain. It was a typical pain with relief on bending forward, multiple episodes of vomiting, had epigastric tenderness, and her serum amylase lipase were elevated. USG abdomen was at this point awaited. Now what will be your management strategy at this point? Yes. So good that we have taken up this question. Most of you have said that the child has to be kept NBM till the abdominal pain and vomiting subside. That's not true. The current guideline says that you have to start enteral feeding as early as possible. That will reduce the chances of superadded secondary infections, pancreatic necrosis, and a whole lot of early complications. The only criteria is the child should be able to tolerate it. So for the pain, if it is mild, you can give simple analgesics, but ensure that the feeds are started as early as possible. Next. One-and-a-half-year-old boy who came with intermittent painless passage of dark blood in stool since 6 months. No crying, no irritability, did not require blood transfusion, was well grown, and there was no abdominal distension or tenderness. The HB was low. Other than that, the stool showed RBCs present. All the radiological investigations, USG, CT, angiography, as well as a colonoscopy and biopsy, all that was normal. So which diagnosis will you consider? Okay, so cow milk protein allergy, we have done a colonoscopy for this child. We have done a biopsy also. CMPA will not be missed on these investigations. Meckel's is the correct answer. Although the CT abdo with angio was normal, only 45 to 50% of the times the CT will pick up a Meckel's. The rest of the times it can be missed. So you have to do a technetium scan because 90 to 95% of patients will be picked up on the nuclear scan. Yeah. We had a 5-year-old boy with jaundice since 10 days, abdominal distension and encephalopathy for 2 days. Had a firm hepatosplenomegaly. I want you to pay attention to the labs here. The HB was low. The transaminitis was present with the AST markedly elevated as compared to ALT. ALK phos was significantly low as compared to bilirubin. So what do you think is the probable diagnosis? So many of you have answered correctly, Wilson's disease. The pointer here was an anemia, which in Wilson's, especially when they present as an acute liver failure, is known because of the copper toxicity, because of which, again, because of that hemolysis, the AST will be markedly high as compared to the ALT. And also the ALK phos in this case, because it is not generated well in the liver in Wilson's disease, is significantly lower. Whenever you have cholestasis hyperbole, the ALK phos you expect to be high. But in a child with Wilson's disease, the ALK phos will be significantly low when you compare it with the bilirubin. There are some ratios given, right now not going into it. Next question. A 6-year-old boy born of second degree consanguineous marriage with jaundice for 6 months, pruritus for 5 months, and some ecchymotic patches over his body. Significant history of death in elder sibling due to liver disease and pruritus in mother in both the pregnancies. There's icterus, ecchymosis, scratch marks, and firm hepatosplenomegaly. So what investigations may give a clue to the diagnosis? Yeah, so basically here we are dealing with a case of PFIC because there is a history of cholestasis in mother during pregnancy. There is a history of liver disease in the child, and there is pruritus. Whenever you have a combination of cholestasis and pruritus, you have to consider PFIC as a strong possibility. Many of you might have marked low GGT because PFIC is classically said to be a low GGT cholestasis, but that is for newborns and infants. But when you come to older children where we are considering PFIC 3, you will have a high GGT. This is a knowledge-based question. A 2-year-old girl is suspected to have very early onset IBD. So which of the following statement is correct? So this was only to sensitize you that there is an entity called very early onset IBD. Any child presenting below 6 years with IBD, you have to consider. Why is it important? It is a monogenic disorder most of the times, may be associated very often with immunodeficiency primary, sometimes autoimmunity, and the outcome will completely change if you do an NGS, prove it, and the child gets IVIG and or HSCT. So your usual immunosuppression will not work here, in fact should not be, because they will many times have immunodeficiency. So this is the reason we have put up this question. The next set of questions are image-based questions. A 6-year-old girl with fever, abdominal pain and weight loss for 4 months. The first are the skin findings. I'll not describe those. After that are the radiological findings, and there's something there in the iliac fossa. And this is the ileocolonoscopy, and whatever we have pointed, you all can guess what that is. So basically the skin findings were tuberculates, not very common, but this was one of our patient only, so they were tuberculates. And on the second picture, you could see some ileocecal thickening with a little pulled ups and deformed cecum. And the third picture of the endoscopy where we had pointed the arrows were all ulcers. They were all circumferential. This was the ileocecal region. And the IC valve also in this patient was very difficult to navigate because it was stricturous. So this was a case of abdominal tuberculosis. Eight-month-old boy with jaundice and pruritus, intermittent pale stools, the dysmorphism as seen, and on auscultation and ejection systolic murmur. What diagnosis will you consider? Look at the forehead, look at the nose, look at the chin. Clues. Yes. So it was a broad forehead with a bulbous tip of the nose and a pointed chin, triangular faces. The point I want to make here is this was still when the faces had evolved. But when you see these children in the early months, newborns, para-neonates, they will not have the typical faces. So you should not rule that out just based on the fact that there are no faces seen. Okay, we have gone on, sorry. 5-year-old boy with accidental consumption of drain cleaner and followed by burning, ulcers. This was the upper GI finding. I'll tell you that this is a circumferential involvement with a lot of deep ulcers. However, I'm not able to see any gangrenous necrotic changes there. So what should be my line of management? Yes, I think we moved on a little faster. Can you show them? You cannot show them. Don't move on till I tell you that you have to move on. Okay. No, so basically I'll just explain. This was, since it was a circumferential involvement, there was a very high, and it was deep ulcers, there's a very high chance of stricture formation. To avoid the stricture formation, we prefer inserting an RT, but it cannot be done blindly without an endoscopy because we'll end up perforating. So during the endoscopy, under vision, we put in an RT, keep it, and then after 4 to 6 weeks, we do a barium and see if there are any strictures, and then we dilate them endoscopically. And this child will have to be kept NBM for some time because of the circumferential involvement. If it is not circumferential, then you are safe to start the child on feeds once he starts tolerating, very slowly, like we increase after any surgery. However, if there are necrotic changes, then keeping NBM is an essential thing. So this was a 15-month-old child with steatorrhea. These were the eye findings, a peripheral smear, and the biopsy. Yes, so hemat and GI go hand in hand. Yes, so this was quite a simple case. Most of the residents also luckily have identified the acanthocytosis, so their hemat as well as GI is very strong. The last thing what you saw in the biopsy were fat-laden intestinal cells, enterocytes. And first was, of course, vitamin A deficiency. Next. An 11-year-old girl with recurrent abdominal pain for 4-5 years, and there is also inadequate weight and inadequate height gain. There are bulky, foul-smelling stools that are difficult to flush. This is the X-ray. We have given the pointers to some of the findings. I don't know if they are very clear from there. Okay, I'll say there were some radio-opaque spots where the arrows are marked. That much I can tell you. Yes, so basically wanted to tell you about the fact that steatorrhea should not be missed. How do you ask, this is for residents, how do you ask for steatorrhea? Is bulky stools. Now what do we mean by bulky stools? You compare the quantity of the food that the child eats as compared to the quantity of stool that he passes. So that is bulky. They are foul smelling, and if it is a Western commode, they will float on water. If it's an Indian toilet, they'll be difficult to flush out, they'll stick to the pan. So this history, along with a failure to thrive, will point to you towards a fat malabsorption. Next. A 5-month-old girl with chronic diarrhea for 4 months, anasarca, and a history of inadequate weight gain since birth. And then she had these asymmetric limbs. If you look at her upper limbs, they were asymmetric. And she had hypoalbuminemia, very significant. And rest of the findings were normal except for gross ascites. Even her UPCR was only 0.2. So what is the most probable diagnosis? This was her endoscopy findings, snowflake appearance in the duodenum. Yes, primary intestinal lymphangiectasia. So always think of this cause. Whenever you have a chronic diarrhea with anasarca, ascites, and hypoalbuminemia, you've ruled out a renal cause. Always look for a GI loss of the protein. And your any lymphatic malformation anywhere else in the body will point towards a PIL. I think we are on the last question. Four-year-old girl with recurrent transfusion-dependent anemia, sir, hemat again, starting at 1 year of age, HB dropped up to 3. She came with severe pallor, stunting, wasting, no other bleeding manifestations, no jaundice, no organomegaly, no bony, cartilaginous or subcutaneous swellings. This was on the sole of her feet and a lot of other places on the skin, and these were the scopy findings. So this was again a patient referred to us. This case again, because whenever you have an anemia which is refractory and all the hematological investigation has been done, nothing is found, it can still be a case of occult GI bleed. So please refer to gastroenterologist, get a scopy done, if required CT angio done, and you will get the answer. This was our own patient. We had started her on sirolimus, which is the treatment of choice for this blue rubber bleb nevus syndrome. After 8 to 9 months, she has become totally no blood transfusion required again. We have repeated her scopy. Her lesions have markedly reduced in number also and in the size also. So a right referral at the right time can really save a patient. So I think we are at the end of the quiz. I had to hurry through it because we are already running late. So the third prize goes to Akshata Gauri. Akshata, come. We have prizes for you. Second, Devina. Dr. Devina Datta. And first prize, Dr. Srihari. I hope you all enjoyed the quiz.
Srihari.
Thank you, ma'am, for this fun and engaging quiz. I would like to request Dr. Sadhna to present Prachi ma'am with a token of our gratitude. Moving on to our next session, childhood obesity has become a global health priority, demanding action beyond the clinic and into the communities. The condition reflects a complex interplay of diet, lifestyle, and socio-environmental factors. Combating it requires not just awareness, but a cultural shift towards healthier living. I invite the chairpersons for this session, Dr. Shailaja Poddar and Dr. Yashwant Gabhale. Dr. Shailaja Poddar is an additional professor at Rajiv Gandhi Medical College, Thane. She has been the head of Department of Pediatrics and Neonatology, as well as the in charge of Pediatric Palliative Care and the MU coordinator there. Dr. Yashwant Gabhale is additional professor at the Department of Pediatrics, LTMMC. He is the program director of the Pediatric Center of Excellence for HIV and the in charge of the Nutrition Rehabilitation Center, NRRTC. I would like the chairpersons to introduce our speaker, Dr. Nikhil Shah.
Good afternoon, everyone. Since morning, we have been witnessing various topics through our kaleidoscope. And now coming to another interesting topic, that is small changes and big impact, fighting the childhood obesity. Fighting childhood obesity is being a big problem. Up till now, we were thinking undernutrition is the only problem, and that was very alarming to us. But now the childhood obesity is becoming a bigger problem. So how to deal with this childhood obesity through small changes? So we have a great speaker with us, Dr. Nikhil Shah. He is a consultant pediatric endocrinologist. He is attached to various institutes like Sion Hospital, KJ Somaiya Hospital, Surya Hospital, Cloud9 Hospital. And he is a consultant pediatric endocrinologist. And he has done his work in obesity, thyroid disorders, and other endocrinal disorders. He is also a co-convener of CIAP Obesity Guidelines 2023. So over to you, Dr. Nikhil Shah.
Thank you, organizers, for giving me this opportunity. At the onset, I'd like to thank Radha Gildayal Madam also, because without her unwavering support, our Department of Pediatric Endocrinology has gone from strength to strength. So I'll straight away dive into the topic, not waste time. So I've been given the responsibility to talk on small changes, big impact, that is fighting childhood obesity together. So unfortunately, this is the evolution of man right now. This is what we're going through. So what I'll be talking about in the next 20 minutes will be based on the IAP guidelines on obesity, which we were lucky to be a part of. So these guidelines basically had 20 experts from all over India. We had 29 recommendations across 6 subheadings and was published in Indian Pediatrics in December 23. To make it more fun and interesting, I've made it case-wise so it doesn't get monotonous. So coming to the first case, it's an 11-year-old male, previously well and developmentally normal, born SGA, birth weight being 2.3 kilos, now comes with the complaints of small size phallus. Now, is this a micro penis? So no, this is a buried penis. This is a pseudo micro penis. SMR examination revealed that the child is pre-pubertal. They also come with complaints of chest swelling. This is nothing but, this is not gynecomastia, this is lipomastia. And this is the most common complaint. They go to dermats for the blackish discoloration of the nape, underarms as well as the thighs. This is acanthosis nigricans. Unfortunately, obesity patients do not come to us for obesity. They come for all these complaints. That is the sad part. So I think it's very important. That is what is the first recommendation in the guidelines. We recognize and treat pediatric obesity as a chronic disease, which is characterized by excess or dysfunctional body fat, which impairs health, leading to long-term morbidity and early mortality. Now, the second most important question, especially for the residents, is how do we define overweight and obesity? Above 5 years of age, we use BMI, that is the IAP BMI charts. Under 5 years of age, we use the weight for height, that is the WHO charts. So above 5, we use the IAP BMI charts. Below 5, we use the weight for height WHO charts. So just for you all, this is the IAP BMI charts. If we look at it, anything above the orange line, that is overweight, that is equivalent to the 23 adult equivalent. Anything above the red line is obese, that is above the 27th adult equivalent. So anything above the orange is overweight, anything above the red is obese. For weight for height or weight for length, that is in children under 5 years of age, overweight is defined as anything is equal to or more than +2 standard deviations. In obesity, we define it as equal to or more than 3 standard deviations. So overweight is above +2 standard deviations, obesity is above 3 standard deviations. Now in the guidelines, we also publish these extended BMI charts now. Because we are seeing more and more cases of severe obesity, this helps us in prognostication as well as treatment purposes. So we've defined something called as class 2 and class 3 obesity, which is based on the 120% and 140% of the IAP obesity cutoff value of 27 adult equivalent. Now coming to the basics, this is what a growth chart is. So how do you interpret this growth chart? You can see that the weight of the child is on the 90th percentile, height is on the 50th percentile. Now if I drive this height ahead, you can see that the child is taller than the MPH target range. So this is actually a tall child for his parents. BMI was 22.7, so on the BMI chart, the child is obese. So this is a tall and obese child. So as I teach my residents in the OPD, any child you see, you first see whether it's an early onset obesity or whether it's a childhood onset obesity. If it's a childhood onset obesity, you look at whether the child is short and obese or tall and obese. Tall and obese is nothing but exogenous, primary or lifestyle related obesity, which could be metabolic syndrome, PCOS, type 2 diabetes or just simple obesity. So this is where we need to understand. Everyone feels that obesity means it's an endocrine cause. No, 90% of cases of obesity, childhood obesity, it is an exogenous or a primary obesity or a lifestyle related disorder. It's very important as a clinician to differentiate between exogenous and endogenous obesity. So exogenous will be tall and obese, endogenous will be short and obese, as evaluation and management changes depending on the cause. This is one thing we are always trained to take history, but in obesity cases, somehow these are the small things which we are missing. So what is the importance of social history here? Diet history, physical activity, screen time, and sleep. So any kid of obesity, basically I tell them to maintain this diet diary. Because every parent says, Mera bacha to kuch khata nahi hai. And if you look at this child, morning there is a biscuit, then there is biryani, gola, biryani, biryani. Biscuit, chawal, gulab jamun, gola. So jo bacha khata nahi hai, you can see the amount of food is eating in a day. So the father had a shop, so the child keeps on eating at the shop. This is another child. Now look at the amount of times he's eating in a day. 1, 2, 3, 4, 5, 6, 7, 8, 9 times. So these are the things which we need to make the parents realize and the child realize that this is not correct. So that's what I just asked for, a diet diary. It just makes things easier for them to understand that this is how much they're eating. Second thing which I do is, on the phone there is something called as a digital well-being app. So any adolescent boy who comes, I ask them for the phone. So you can see how much time they spent on which app. So again, parents say कि पता ही नहीं time कहाँ पे जाता है. Child says नहीं, I go for exercise. And then you can see this child, 1 hour 40 minutes on Instagram, 1 hour 30 minutes on Facebook, and in a day he's spending roughly 7 to 8 hours on the cell phones. So in all the phones, you have this digital well-being, which can tell us how much the child is spending how much time on. So in our child, the child had 0 physical activity, 3 hours on the mobile phone, 2 to 3 hours on the TV, sleeps at 2 a.m., gets up at 10 a.m. So horrible lifestyle. So what is the next important step in any child who comes to you with obesity? After plotting on the growth charts for the BMI, the next thing which we do is plot the waist circumference. It is very, very important that waist circumference should be measured in all overweight and obese children because it is a key measure of cardiometabolic risk. So again, we have waist circumference charts. All these charts which I have mentioned so far are available on the IIP website. We should be using them. Any waist circumferences which is more than 70th percentile is important because these children are at a risk of developing metabolic syndrome, hypertension. So in this child, the waist circumference was 80. It was much more than the 70th percentile. Now, how do you evaluate a tall and obese child? So this is what we've mentioned in the guidelines. These are the recommendations. Any obese child more than 10 years of age, irrespective of risk factors, obese children between 2 to 10 years of age, if there are risk factors, and overweight children, if there are risk factors, we should screen for comorbidities. Now, what are these risk factors? Risk factors means a strong family history. That could be in terms of obesity, dyslipidemia, premature coronary artery disease, hypertension, diabetes, or if the waist circumference is more than 70th percentile. So all these children should be evaluated for comorbidities like hypertension, diabetes, fatty liver, and dyslipidemia. Routine evaluation for an endocrine cause in tall and obese children, we do not recommend. We screen just for comorbidities. So in this child, the BP was fine, sugar was 88, so which was normal, SGPT was fine, lipid profile was normal. So how do you manage exogenous obesity? Easier said than done. Lifestyle modifications, lifestyle modifications. This is where again we as pediatricians, as clinicians need to spend that 5 minutes extra to explain them about the 4 pillars of lifestyle modifications. First being nutritional management. We talk about balanced diet, appropriate portion sizes. Let the child determine the portion sizes. Let not, keep on giving the child, and avoid junk food. So again, we have the guidelines for junks. What is the full form of junks? That is junk food, ultra processed foods, nutritionally inappropriate foods, caffeinated, colored or carbonated drinks, and sugar sweetened beverages. Dietary intervention should be culturally acceptable. So in South Indian, we can't just tell them to stop rice. We have to find alternatives. They should be healthy, family-oriented, affordable. We can't keep prescribing quinoa to everyone. It has to be, affordable to them and ensure long-term compliance. The target in younger children has to be weight maintenance, not weight loss, because as the height will increase, the weight will stay steady, the BMI will drop. So we focus more on weight maintenance than weight loss. Second pillar of lifestyle modifications is physical activity. Again, we have guidelines for this. Age-appropriate, moderate to vigorous physical activity for at least 1 hour per day is recommended for all children. This should be in the form of aerobic exercises like cycling, jogging, swimming, badminton, football, or dance. Infants, toddlers, preschoolers are encouraged to remain active throughout the day through age-appropriate activities. Please do not restrain them for more than 1 hour in terms of prams, high chairs, strapped on the back. So less than an hour is what we need to restrain them for. This is the sad fact. In 1990, the TV was much bigger than us. In 2008, it's the other way around. So screen time, as Dr. Dalwai already said, that screen time has to be managed in these children. The recommended screen time, again there are guidelines for this, is 0 up to 2 years of age, maximum 1 hour up to 2 to 5 years, and 2 hours from 5 to 10 years. After 10 years, it is age-specific, which has to be balanced with age-specific developmental goals. This is the recreational screen time. So a lot of the children will argue, ki, sir, we get so much, homework and also. We are not talking of the homework, we are talking of the recreational screen time. And finally, sleep hygiene, which all of us forget. 0 to 5 years, at least 10 to 11 hours of sleep. 5 to 10 years, at least 9 to 10 hours of sleep. And greater than 10 years, at least 8 to 9 hours of sleep. So this is what we need to tell them. Finally, what I tell them is obesity is a disease of the entire family, not the child alone. So if we tell them ki no screen time, that means it is applicable to everyone. If we tell no sweets, no maida, no processed foods, that is applicable to the entire family. We say exercise, even the parents have to exercise. So lifestyle modifications should apply for the entire family. This is just a simple funda which you can tell your patients in a busy OPD, that is by the AAP, that is the 5210. So at least 5 portions of fruits and vegetables, less than 2 hours of screen time, at least 1 hour of play daily, and 0 sugar caffeinated beverages. I think all of us know about these sugar boards. CBSE schools have mandated this. So other days, now even patients know how much sugar should be there in how many cold drinks. So it is important that we as clinicians who are associated with schools should encourage sugar boards in schools, which is mandated by the CBSE board. And a lot of us are active on social media, unlike me. So I think this is where we need to make our public aware about choosing the food labels. Do not go what is written ahead. Please look what is behind. So look at the contents, look at the total calories, avoid things with trans fat, avoid things with added sugar. These are the things which need to be explained. So coming back to our case, we are clinicians. We just advised 1 hour of cycling and football to the child, dietary modifications, decrease screen time to less than 2 hours, no medications. I'm not a fan of medications in obesity. Weight loss of 4 kilos was achieved in 6 months. BMI is now overweight. This is just by simple lifestyle modifications. Could we have prevented this? So I don't mind you all don't listen to the entire talk, but this is one slide I want everyone here to focus on, especially residents. This child was born as an SGA, the birth weight being 2.3 kilos. At 3 years of age, what you can see is that the height has caught up to the mid-parental height, but the weight is still lacking behind. The weight is below the 3rd percentile. So in SGA babies, if the child is a little bit underweight, let them be underweight. Don't focus on the weight, please focus on the height. If the child is caught up in terms of height, it's okay. Because if we focus on the weight, what happens is we tend to unnecessarily prescribe these protein powders and parents want to start high calorie foods. So what happens in these SGA babies is, at that age, when you start all these protein powders and high calorie feeds, it leads to an inappropriate weight catch-up. It leads to early adiposity rebound, and leads to childhood obesity. So please chase heights in small birth weight babies. Do not chase the weight. If they're a little bit underweight, but height is within the mid-parental height percentile, let the weight be. Let them be thin. Coming to my second case, it's an 11.5-year-old boy, previously well and developmentally normal, birth weight being 4.5 kilos, known case of bronchial asthma, a recurrent visa. Now complains of recent onset weight loss, loss of 5 kilos, polyuria, and increased tiredness since 1 month. On examination, classical severe acanthosis, skin tags, that is acrocordones are present. There is no goiter, white stria present on the abdomen. The blood pressure of the child is hypertensive. These are all real life case scenarios. And the child had buried penis. So on examination only, we found that the child has hypertension and insulin resistance. Now going back to the growth chart, weight is greater than the 97th percentile, height is on the 90th percentile, height is greater than the target range of MPH. So this child, if we'll again trace the height, it is taller than the MPH. So this child is tall and obese. So this is nothing but an exogenous or a primary lifestyle related disorder. Another important history that we tend to forget is importance of family history in these cases. So in this case, both parents were also obese. Both had type 2 diabetes. Both parents developed type 2 diabetes before the age of 35. Mom is on oral hypoglycemic agents. Dad is on OHA plus insulin. So we always assume that diabetes mein genetic risk is in type 1. No, that is absolutely wrong. If one parent has type 2 diabetes, the risk to the offspring is 30%. If both parents have it, the risk is 70%. Same thing with obesity. Type 1 diabetes, the risk is not so high. So actually in type 2 diabetes, the risk is much more higher to the offspring. So as I said, in any tall and obese child, don't forget to screen comorbidities. It will be from head to foot. They can present with idiopathic cranial hypertension, you can have hyperreactive airway disease, you can have kidney disorders, bony complications like genu valgum, psychological issues, and all the metabolic issues that we've discussed. So coming back to our case, it's an 11.5-year-old boy with obese, tall and obese, with recent onset weight loss, both parents having type 2 diabetes. Fasting sugar was 300, postprandial sugar was 456, urine ketones was 1+, so not in decay. HbA1c was 11.2. Lipid profile normal, SGPT elevated, so child has already symptoms of fatty liver disease or NASH or MASLD as you call it right now. Insulin not checked as because acanthosis was present. C-peptide was normal, all antibodies were negative. This is type 2 diabetes. So as a resident, I was always taught, you see diabetes in children, it's type 1 diabetes. Gone are those days. We are seeing type 2 diabetes very, very commonly. The youngest type 2 that I have in my practice is 9-year-old. So 9-year-old children are also developing type 2 diabetes, so that's why we need to be careful right now. So we started on long-acting insulin once a day and on metformin twice daily. Within few days, the sugar started normalizing. Insulin was tapered and stopped over 2 months. Again, please never forget diet and exercise. That is the main pillar. Sugars have normalized right now, and HbA1c on follow-ups are between 6 and 6.5. So this is where I think today everyone is talking of that magic pill, the magic injection. Everyone's talking, these companies are making a lot of money. What is the role of pharmacotherapy in childhood obesity? So we reserve it only for the rarest of rare cases. In children, again, lifestyle modification is the key. So an adjunct use of pharmacotherapy, so it's adjunct. I'm underlining the word 3 times. It is an adjunct to a comprehensive lifestyle program, modification program. So we advise pharmacotherapy only in children having comorbidities, or if it's a class 3 obesity, so it's a very severe form of obesity, there only we advise pharmacotherapy. Otherwise, pharmacotherapy is not going to work if you don't follow your lifestyle modifications. Coming to my third case, I'll try to wrap it up fast. 5-year, 9-month-old girl child, previously well and developmentally normal, weight gain and lethargy since few months. So I saw this child during the COVID period. So everyone attributed कि अरे COVID है तो वो lockdown की वजह से weight बढ़ा है. So everyone ignored that. So on the growth chart, as you can see, the child's height is on the 3rd percentile, but the child is actually short for the MPH. So previous 2 cases I showed were tall for the MPH. So this child is short and obese. So going back to the algorithm, childhood obesity, short and obese, think of an endocrine cause. So this is the child on examination. So you can see there is a sallow complexion, periorbital puffiness, the child looks puffed up, there is dry skin, there is thelargy, there is pseudoacanthosis. So I think you all know what the answer is. Just for workup, we did a bone age which was grossly delayed by more than 2 years. TSH was 550, free T4 was undetectable, thyroid antibodies were positive. This is nothing but juvenile or autoimmune hypothyroidism. So again, what the guidelines we've recommended is endocrine cause should be evaluated in short and obese children with additional diagnostic clues. So clinical examination growth chart will give you the diagnosis. This is the child on follow-up. Within 1 year, just by starting on low-dose thyroxine, you can see a massive improvement in the height, and you can see the child much more active, much more smiling. Coming to our 4th case, the last case, this is a 6-year, 6-month-old girl child born to 3rd degree consanguinity. Weight being 35.9 kilos at 6 years, where the weight should be roughly 20 kilos, the child is almost double. A younger sibling has similar complaints. If you closely look at the fingers, can you all see anything? So there is polydactyly there in all fingers. So so this is polydactyly with developmental delay, born to a 3rd degree consanguineous parentage. So coming to this obese child, early onset obesity. If you have dysmorphic faces, polydactyly, vision or hearing impairment, think of a syndromic cause of obesity. So this is where the guidelines have also made that we do not want to do rampant genetic testing in all. Genetic testing should only be recommended for rapid or early onset of obesity if it is less than 5 years of age with hyperphagia, clinical pointers and or family history of suspected syndromic obesity. So on follow-up, we got the genetic report of the child. This is nothing but Bardet-Biedl syndrome. So we could then send to the ophthalmologist, they worked up for retinitis pigmentosa and all of that. So what are my take-home messages? Under 5 years of age, please use the WHO weight for length charts to diagnose overweight obesity. Above 5 years, please use the IAP 2015 BMI charts. Important to differentiate between exogenous or lifestyle-related obesity, that is from the secondary or endocrine. So please differentiate whether it's tall and obese, short and obese. That tells you what tests to do, what tests to order. In all overweight and obese children, measure and plot the waist circumference. That tells us about the metabolic risk that the child is having. All obese and overweight children, especially if risk factors are present, should be screened for comorbidities like hypertension, fatty liver, hyperglycemia, dyslipidemia. Lifestyle modifications is the key. I'm going to keep harping, but this is the key. Drugs are not the solution. Lifestyle modifications, that means nutritional management, physical activity, screen time, and sleep hygiene is still the cornerstone of management of childhood obesity. pharmacotherapy is only indicated in severe obesity or if comorbidities like dyslipidemia or diabetes is present, it is always as an adjunct. Again, I'm doubly underlining this to lifestyle modifications. So, thank you so much.
Yeah. Thank you, Dr. Nikhil, for the very informative talk. And since here, chairperson.
Sorry.
Since we have a NRC, center,
yes, sir.
And we do see a spectrum from malnutrition
to malnutrition.
to malnourished.
Malnutrition. Yes.
Yeah, we call this as malnourished because the junk food, which you have highlighted very promptly. And I think it is every parents, we should be like you said about displaying the in the canteen. They must be having this all Coke and now Diet Coke.
Yes. So all these CBSE schools, even in my son's school, the sugar board is displayed.
Yes.
I was called by one of the school principals to help us,
So
set
whenever
the
you
sugar
go to a
boards.
parent-teacher meeting, you should be saying all these things to the principal, and that should be highlighted. And as a parent, we should be aware of this thing. And because it's a culture now, Zomato, Swiggy is there. Please order, and we get emotional blackmail. We don't have that much of time. So we should not get that blackmail.
No.
As Samir has already said about screen time also, you also highlighted that screen time is also very, very important because they just keep eating and seeing the reels and all that. So thank you very much for
Thank
this.
you, sir.
And ma'am.
So my question to you, there are two questions. One is, do you have an answer for geriatric screen time? Retired people, post-retired. I know you are in pediatrics, but maybe because you're talking so much about screen time, I just thought I'll ask you.
I can maybe give an example at my home. So my parents also staying with me. So I think all youngsters should have a kid. They'll take care of the kid. So then the screen time will decrease, madam. So as grandparents,
those kids are abroad, usko kya karne
that
ka?
is difficult, ma'am. So I think some sort of hobby we should develop. There are a lot of these communities where you can now go to the club and play. So there are hobbies. It's up to us whether we want to do it
But
or not.
how much is now today? Both of us have seen for at least 1 hour, 4 minutes, and 1 hour, 10 minutes. No, not between. Each one of us individually. So I thought that was less because that's okay. But sometimes when I look back at the week, there are 4 hours sometimes,
ma'am.
3
Yes, ma'am.
hours. Because sometimes... अभी जिम तो जाती हूँ उसके बाद क्या करूँ और फोटोज तो देखा ना आईआईपी मुंबई पे no so that is in the lighter vein but second serious question about that 11.5-year-old child that you showed with both parents having type 2 diabetes and the child having at 11.5 years type 2 diabetes. Suppose the parents had been vigilant and taken care of lifestyle in this child before he grew up to be 5, 6, 7. Would diabetes be averted?
Yes, ma'am. So it's always genetics and epigenetics, ma'am. So
Together.
genetics is always going to play a role, but the epigenetics, that is the environment, if they would have control, not every parent who has type 2, their children develops type 2.
Right.
So I think here the epigenetics kind of pushes the child into developing diabetes, I would say
It's
that.
a bit too early, means I
Ma'am, I'm
can't
seeing as young
recollect
as
in my
9
career.
and 10, ma'am.
Yeah,
So
9 years, 11
'cause
years,
now
we have
we-
never had diabetes, mellitus.
it's horrible. The father is already on insulin, ma'am. So father is already on insulin. Family is
No
that's the problem.
lifestyle,
That's the problem. So that's the reason the last statement I always say in my OPD is keep please, this is what I've advised is not for the child alone, it's for the entire family. If you say no for the packets, it's bad.
And one more last thing I want to request you as
Yes,
an
ma'am.
appeal. Can we do something about sleep hygiene amongst the younger generation? There is no time when they go to bed. They sleep at any time. They wake up at any time. I mean, I know all my nephews and nieces who are now working, yet they don't sleep before 1 a.m., 2 a.m. and don't wake up before 10 a.m. So I wonder because I go to bed at 10:30, 11 and they are all awake and they want to make calls and messages and I tell them no, tomorrow morning. So can you do something to alter that in the community? I mean, this is very crucial and urgent.
So I think that's where the role of IAP, so Dr. Upendra and the other dignitaries will help us, you know. So.
Pardon, I just want to ask a
ma'am.
small
Yes,
thing
ma'am.
related to diabetes. Since it's a lifestyle modification disease, if the lifestyle is altered,
reverses, ma'am.
it will reverse the
Yes,
diabetes,
ma'am. So
isn't
a couple
it?
of children have been able to stop the medication and they are off the medication for 2
Because
years.
honestly, that way type 1 is the one which is
Yes,
so
ma'am.
tough.
Yes, ma'am.
You know, for lifetime you have it.
Yes, ma'am.
Whereas you can reverse your lifestyle
Absolutely
and
correct,
change
ma'am.
it.
Yes, ma'am.
That's what, right?
Yeah, thank you so much, Nikhil. I'm very happy that Nikhil was the co-convener and he proudly presented our national obesity guidelines, and his entire talk
it was
based.
first dream to have these guidelines.
So on 1st of January, when I took over, the first call I made to Dr. Vaman Kadilkar that this year, before I complete my tenure, we should have, because we do not have any pediatric obesity guidelines. I'm very happy to say all the neighboring countries, pediatric societies contacted me, the Sri Lanka, Philippines, Vietnam, they do not have. Pakistan, Sri Lanka also, Bangladesh, and they all said, can we use yours? So I said, yes, definitely, because all the same kind of food, the same kind of children, and we have the same problems, so we can all use it. So that was number one. And number two, talking about the screen time or the junk food, again, the second initiative which I took and which is still continuing, the Sankalpa Sampurna Swasthya program, it is still continuing on. And if you want, those who want to one, madam, you're talking about sleep hygiene, we talk about sleep hygiene in that part also. And it's a 2-hour module for children between from 8th standard to maybe 11th, 12th, we did it for first MBBS also. So anytime if Sion Hospital, pediatric department, your residents or anybody wants, any of the schools, we can come, myself, Dr. Amin here, there are so many of them, they're already trainers. So it's a 2-hour program, you watch it and you can go in the schools. Before this sugar board came in CBSE, again we are happy, we started this initiative much before, the food farmer also started it, but then before that we had initiated. So all in all, the time is to go to the school and talk to the school children. So note down the IIP website, iipsss.org. If you want to do the program, we are all very happy to have
I'm
it.
just asking you, the sleep hygiene program, you go and talk in schools. Have you done an outcome and impact?
Lovely question. So again, let me go again and tell you that in there is a university at Nashik. I just forgot the first university. Dr. Leena, she's the HOD of pediatric. She's the dean of the college, and then she has given it as a thesis topic to her student. So they have taken 100 schools in and around Nashik, and they have done before program and after 1 year. Not after 1 month or 2 months, after 1 year, the analysis of this, and they would be coming out with what kind of findings, what changes they have done. So it is not only one, the impact also has to be analyzed, so that would be done there. SMBT University at Nashik, so this program has been taken by them.
So if you're able to give us a feedback on that, maybe you'll get more people who are willing to go and talk
Absolutely.
this thing everywhere.
And it's an interactive program, so it's not a lecture from the stage, so we can have all it. Thank you, Nikhil.
Thank you, sir. Yes, ma'am. Correct, yes, ma'am.
Should prevent
Yes.
by advising the parents when they come for the
Correct, yes,
vaccination around the age of 5 years. They start putting on the weight from the age of 5 years
Yes,
onwards.
yes, yes,
So
yes,
that's the
ma'am.
time what you say that the weight has to be controlled
Yes.
and checked and the height can be
Yes, yes,
monitored,
yes,
you know.
yes.
This is we pediatricians should
Yes,
make
ma'am.
the awareness
It's
to the
primarily
parents.
a
and
pediatric
children.
disorder, ma'am,
Yes,
than a
it's
pediatric endocrine disorder. So
Yeah.
that's the thing.
Thank you very much. Yeah.
Thank you, sir. Thank you, ma'am.
Thank you, sir, for your valuable insights on this global health problem of childhood obesity. I would now request the chairpersons to present Dr. Nikhil Shah with the token of appreciation. I request Dr. Sadhna Zope to present our chairpersons with the token of appreciation. Thank you all. Moving on to our last panel discussion for the day, which is sponsored by DRL. Vaccination remains one of the most effective and evidence-based interventions in the history of medicine. It stands as a cornerstone of pediatric health, preventing countless cases of illness and death worldwide. Each child vaccinated is a life protected, a family safeguarded, and a community strengthened. However, emerging infections, vaccine hesitancy, and evolving pathogens remind us that vigilance and innovation in vaccinology is more important than ever. May I again call upon Dr. Upendra Kinzavdekar sir to moderate this session. May I call upon our esteemed panelists, Dr. Mukesh Agrawal, Dr. Bhagyashree Seth, and Dr. Amin Kaba. Dr. Mukesh Agrawal sir is a professor of pediatrics at KJ Somaiya Medical College, Mumbai. Sir has been the ex-professor and head of Department of Pediatrics at Seth GS Medical College and KEM Hospital. Sir has written 6 books, including Immunization in Practice and Textbook of Pediatrics. Welcome, sir. Dr. Bhagyashree Seth is a professor of pediatrics at MGM Medical College and Hospital, Navi Mumbai. She is also the in charge of the Thalassemia Daycare Center at the MGM Hospital. Welcome, ma'am. Dr. Amin Kaba is a consultant pediatrician at SRCC Children's Hospital, Masina, Saifi, and Jaslok Hospital. Sir has been the ex-honorary professor at GGMC and a nodal officer for the MR campaign. Welcome all, and over to you, sir.
Thank you so much, everybody. And again, the DAFWAL organizers for giving us this opportunity to interact. Sorry, we have got a little ahead, delayed schedule, but at the same time, appreciate the patience of Dr. Mukesh Agrawal, Dr. Bhagyashree, Dr. Amin, and thank you for being here with us. And let's try to... Madam, तुम्ही इतना दिसला नाही मला. Organizers, काही बोलू शकत नाही. So I think what we'll do is we'll quickly try to go through the important questions that we feel that as pediatricians, even I can see many of the residents over here, they are going to be future in practice. And before I proceed ahead, Shrihari, Devina, and Akshata, I think all of you, once you pass, first thing you should do is apply for IIP membership. That is very essential. I'm sure your HODs will do that. So I think we're all... Hello? Audible now? Naita मला एक hand mic द्या. So this is the baby telling, not vaccinated, no cases. I wish every baby says that, and if it is so, I'm sure we'll be having great vaccination percentage. We all feel vaccines are so easily available, why not use it? But remember, 1 in 5 children globally do not have access, so we are so lucky that we are able to offer vaccination to the most deserving and needy children. So let's quickly go through the general questions that come across in day-to-day practice, as well as some questions that keep coming to our mind and throw some challenges to us. So this is a general principle. Let's start off with, and Mukesh Agrawal sir, let me begin with you. What is a pre-vaccination checklist quickly before I begin my session of vaccination that you would say, yeah, this is essential? 3, 4, or 5 points that you would say are a must before you start with your session.
Thank you very much, organizers. And thank you, Upendra. Now, the question about the pre-vaccination screening. This is something which is most neglected, but the most important component of the immunization services. Because many issues which crop up after the immunization that can be solved at this stage. Now, what I think, 3 things are important when the patient comes for the immunization. Number 1, you review the immunization records, find the correct age, whether the dose should be valid or not, what doses the child has received, what doses are due. So number 1. Number 2, you find out whether there is any contraindication or precaution that you have to take in this child. Contraindication means you cannot give the vaccine. Precautions means you have to give the vaccine, but you have to take care. And third thing that I think that you screen the parents also. Whether when you are advising the additional vaccines, costly vaccines, whether the patient will continue to take the further doses also. Absolutely. If the patient is not going to continue, there is no sense in this thing, then we can send to government setup. So it is better that we screen the patient for the indications, for contraindications, and for the affordability of the patient for the vaccines.
Bhagyashree, one more point to add on to this?
Yeah, like I'm reminded of Mohan Joshi sir's anecdote which he told, and he said, आपने बताया नहीं क्योंकि आपने पूछा ही नहीं. So that we have to remember that we ordinarily, normally when we are vaccinating, we are not giving any checklist to the parents to put a tick on. So any serious illness, any bleeding disorder that the child is having, any previous vaccination, did the child suffer from any allergic anaphylactic reaction? And of course, whatever sir said, date of birth, most important. We encounter a lot of Nepali children whose date of birth is as per the Vikram Samvat year. And so we have to actually calculate and figure out what is the age of the child, because they are running in 2078 year. And we have to then figure out what year actually they are in. So
Amazing.
date of birth, very important. And you should have a sort of a
Conversion
method to
table.
convert the Nepali calendar into this thing.
Look at that, what kind of challenges. Amin, anything more? One point.
I'd like to thank you organizers for having me on board. I mean, Sion becomes like a second home for me today.
Lovely.
I'd like to add a little more to this. One thing is history of any medications the child is on. Many a times we have so many hyperreactive airway disease children. Child may have been on steroids for all you know. Any history of allergy is very important, and something that most of us are guilty of ignoring is a complete resuscitation equipment available right at the cot.
Perfect.
Like a crash cart or something, because I mean, vaccine Shah is not here, but that line always rings in my memory every time. If you haven't got a anaphylactic reaction in your clinic up till now, you'll have it tonight.
So be vigilant.
It's that scary. So your adrenaline, please keep check that it's not expired. Your laryngoscope, your blades, your Ambu mask, oxygen, IV access, hydrocortisone, CPM, AVIL injection, and IV fluids and all. So the
Resuscitation.
entire CPR thing should be there with you.
I think they've all covered almost everything. So 5 important essential questions that we must all ask is, first of all, how is your child today? Number 1. Number 2, what kind of vaccines? Did your child receive any vaccine in last 1 month? If the child says 2 दिन पहले MMR लिया था और आज आपके पास varicella के आ गया तो क्या है? So any other vaccine taken in last 1 month? Is your child on any long-term medications? As she said, steroids or anything? Was your child admitted? If the child had something like, you know, IVIG, he had taken 2 gram per kg just 7 months ago, and then you are planning for some other vaccination, very important. And of course, any untoward reaction to earlier vaccination. If we do that and keep this resuscitation tray ready, I'm sure that we'll be having a proper checklist ready with us.
And take the opportunity to growth chart. Use the growth chart. Most important.
Bhageshri, anything elevating discomfort or pain associated quickly? So I'm sure that everyone must have seen, there is a Insta video of one person in Gujarat.
I was going to mention that only. So there are so many YouTube videos of a particular doctor who distracts the child and gives the vaccine in no time. So that, of course, if you are creative, you can use those distraction methods. I don't know how busy pediatricians are in private practice to really use it for every child. But of course, breastfeeding, I think, is the most soothing thing which you can do before and after the vaccination to calm down the child and alleviate the pain. And some people have used in the past sucrose, concentrated sucrose solutions also,
24%
because that also is known. And the other thing which you can do is that if you are vaccinating with many vaccines at a time, preferably keep the vaccine which is going to cause the most pain the last.
Absolutely.
Those are few things which you could.
I mean, anything, the spray which comes, the lidocaine, isopropanol, does it have any impact?
So it's just a surface anesthesia. I mean, finally the muscle, when it is touched, it's going to do it. And I strongly believe that much time it takes. I mean, if you really have time, you have some really fussy parent from South Bombay, you put a nice Embla patch over there, let them roam around for 15 minutes, relax, and then come. And these are practical things. I mean, when you practice, you do all these things so many times. Many of it is playing on the parent's psychology rather than the kid. So that also works. But yeah, breastfeeding, as ma'am said. Ma'am?
अभी सोबो के लिए बात मत करो, पूरा मुंबई ऐसे ही होने
लगा. Other thing is about other thing is about the technique of not aspirating before giving the injection,
Absolutely,
which is
very
now
important.
not advocated.
We are not supposed to aspirate, hence I think that practice everybody has started. Dr. Mukesh, is paracetamol prophylactic for pain relieving?
No,
A big
definitely
no.
no. If the patient develops fever, you treat it.
Absolutely.
But there is no sense in giving a prophylaxis of that.
Ice application would help cooling this thing. But one thing that a lot of so-called well-wishers give, applied thrombophоб on it. A strict no.
Absolutely.
And one thing I feel that the most comforting thing for the baby is to have the mother with her.
Absolutely.
So it is better that you allow the mother to stay with the child when you're giving the vaccine.
I mean, बच्चे को 99 बुखार है. अभी आज दूँ कि 8 दिन बाद कि बुखार ठीक होने के बाद 1 महीने के बाद, when should I delay in a febrile child and when should I not? Why?
So the standard guidelines say that a mild fever, a mild illness is not a contraindication. Even a mild cold is not a contraindication for vaccination. However, if you feel that you're giving something like a DPT or something which is going to give high-grade fever, and you're unsure about the kind of development of symptoms, and you'll not be able to differentiate between the fever being related to the vaccine or related to the illness, and you're sure that the patient is going to come back. In a government setup, you're not too sure about it. Then maybe it's safer to give the vaccine, but yes, you would delay it definitely if it's a serious illness. If the child has any kind of danger signs, the child is not.
Of course, that we are not going to say. But as you talked about the municipal situation, I think more often than not, they are ready to send back the child with naak beh rahi hai, aaj nahi. थोड़ी खांसी की है मेरे सामने, आज नहीं. So let's not do that. Very important to understand the child, because compliance is so very important and every visit is so very important. Only thing, even the child is on antibiotic for impetigo, that does not mean that the vaccination should be delayed. So even if the child is on cephalexin, cephadroxil for any of the skin infection, antibiotic ले रहा है इसके लिए नहीं दे सकते. All these are the myths we should not. And Dr. Mukesh, which is the only contraindication applicable to all vaccines and it is permanent?
I think the only contraindication is the anaphylactic reaction or a serious allergic reaction to the previous dose. If that is not there, then all the vaccines, most of the vaccines, immunocompromise is one state for certain vaccine that is there. But otherwise, most important is there is any dose, any reaction with the previous dose.
Egg
then
allergy,
you have to
sir.
be careful.
Egg allergy. Egg allergy.
Egg allergy, nowadays, most of the vaccines can be given safely to the egg allergy except the yellow fever vaccine.
So apart from yellow fever, none of the other vaccines should be denied if the child has, because that is the one which has a specific number of proteins which is prepared in an embryonic chicken egg which is used for preparation. So significant protein load from egg comes in yellow fever vaccine. We do not give it routinely, so absolutely no contraindication for that. Bhageshri, a 12-year-old child comes with unvaccinated. Absolutely nothing has been taken, came from Nepal with Vikram Samvatsar. What's your catch-up plan according to IIP 2025?
So IAP 2025, right?
Or whatever, you use American Academy, I don't mind.
Yeah, you are asking me like an exam question. Why?
तुमको पूछने की आदत है, कभी-कभार उधर भी जाओ.
So you will have to see first, list out all the vaccines and check which are the vaccines which you cannot give beyond a particular age. And now this child is 12 years old. So if you start listing out all the vaccines at a 12-year age, unvaccinated child would not be requiring BCG, but because BCG you would usually not give beyond 5 years of age. Then you come to OPV, likewise you would not be giving OPV to a 12-year-old child. Then you come to IPV, also I think IPV would be only up to 5 years of age. So like that, I'll have to go on listing.
अरे भाई आधा घंटा लग जाएगा.
वही तो है.
Come to the point.
I have to think.
Which is the
so hepatitis B you would definitely give because child is unvaccinated. So you will give him 016 dosing of hepatitis B. You will want to give him either TD, that is tetanus and diphtheria. 2 doses will require to be given if he is unvaccinated. You may give him also, you'll have to give him MMR vaccine.
Yes.
And then of course all the additional vaccines, you would give him hepatitis A, you would give him typhoid conjugate, you would give him varicella vaccine. And if they are affording, then of course human papilloma virus vaccine. Means beyond this age, of course.
12 years.
Yeah, 12 years old, yeah.
Both male and female.
What else have I left out? And if he's from a particular endemic area, then you would require to give the vaccine specific to endemic areas like
I think DTAP becomes a very important vaccine that is first which comes and then followed by 2 doses of DT 1 and 6 months away. And of course, apart from that, the important vaccines, as she said, apart from BCG and OPV, I think rest of the vaccines can very well be given to this child. It deserves hepatitis A, varicella, all are very important vaccines which should. I mean, anything
but as an exercise, like we should have a list of what vaccines you cannot give beyond first time beyond a particular age for the residents.
I mean, anything.
As you said, the first one should definitely be a DTaP, TDAP, yeah. And then the 0, 1 and 6. So the second can be TD, and TDAP is preferable, but at 6 months again. And then the rest as mentioned.
As she said. Now you tell me, I mean, should a child on low dose steroids for asthma receive? What is his asthma? You talked about Suppose the child is on 2 milligram per kg, or suppose the child is on alternate day steroid.
So,
what is it?
yeah. So inhaled corticosteroids, there is no contraindication. If the child is on low dose steroids, alternate day steroids, and something like nephrotic or something, even that is not a contraindication. Any child who's on more than 2 milligram per kilo, or if it's more than 10 kilos and more than 20 milligram, then you should not be giving vaccines at that time, especially the live ones. Otherwise, for a low dose, it's not a problem. The live attenuated ones, you'll end up with an exacerbation or maybe even an aggravated reaction to that.
So, and also those who are receiving steroids for a shorter duration can be given, but if it's going on more than 14 days, then you would avoid giving the vaccine.
So those who are on
dose
large
and
doses-
duration, as well as route of administration. So
Perfect.
as he said, intranasal or inhaled
Topical.
or topical or intra-articular, they can still receive.
So 2
and
milligram per
generally,
kg.
if you are on higher dose or longer duration, after 1 month of stopping the steroids, you can give
very
them.
well give the live vaccine. So 2
Simple
milligram per
thing is
kg.
Rule of 2.
Yeah, 2.
If there is 2 milligram per kg for more than 2 weeks or 20 milligram total, and then in that case you have to defer it for 4 weeks.
Perfect. I think that's very clear. Now, Bhageshri, if a 5-year-old receives an extra dose of DTP or hepatitis B, how do you counsel? Does it
Extra
matter?
dose in the sense,
और एक
another dose
inadvertently,
or
016 हो गया और एक hepatitis B गलती से गया या DTP गया, what happens?
Yeah, so most of the vaccines, there is no harm if there is an extra dose. But some of the vaccines, like I think in TD or DTP, etc., there can be an increased chance of adverse events which can occur. So otherwise, if you've given one extra dose of hepatitis B, it won't matter. But for DTP, probably you'll have to watch out for any adverse effects. That
I
is
think
what.
most important is again communication. If some mistake happens by this or sometimes an expiry date vaccine has been given, first honestly accept. Galti se ho gaya, I probably did not check or whatever it is, but please be reassured that nothing would happen even if this extra dose has gone to your child. I think that's very important
The
to
first
understand.
question was that only whether you have given or someone else has given.
नहीं, मानो पकड़ो हमसे हो गया है तो.
So the first thing is, as you said rightly, accept, apologize, assure, ask the expert, and
don't charge.
ये practical tip है.
And again reschedule the vaccination, whatever.
Yeah,
is
accordingly. Again, don't
So
speak
that's
ill
happened
about
with
your
me.
colleague.
Again, assure about it, because DPT, and always tell them about the adverse reactions. So an extra DPT will probably give a little more fever, a little more reaction. So if the patient is prepared mentally, the chances of them going ballistic is a little lesser.
Absolutely.
I think, and also that extra dose will be considered as invalid, and you will have to still give the actual dose which will come in the scheduled time period.
So when was it given, that also matters. Whether it was given immediately within a day or two or 1-2 साल के बाद दिया, it doesn't make much of difference. Now, Dr. Agrawal sir, influenza vaccine, I was always told it's quadrivalent, influenza A, B, Yamagata and so on, everything is important, but now आपने एक को उड़ा दिया और कहा कि trivalent चालू करो. What is it? Why change? And is it applicable to you?
Previous
and I?
vaccines were sub trivalent. For last 10 years, most of the time the vaccines are quadrivalent, which contains 2 strains of influenza A and 2 strains of influenza B.
Yes.
Out of that, one strain, Yamagata strain, you mentioned that thing, that strain has not been seen for last 5 years. So perhaps that one strain is not required. And now that's why there is a recommendation that shift from the quadrivalent strain to trivalent strain. In fact, last year, adult consensus guidelines for the adult immunization, they have directly mentioned that give trivalent vaccine only, not the quadrivalent vaccine. So it is always better. We also, just now the trivalent vaccines, very few trivalent vaccines are available. I think it is not available at present.
नहीं है, now available.
Hey. So it is better that most of the other vaccines also, they become trivalent. We are giving unnecessarily one strain that increases the risk of side effects also, that increases the efficacy of the other strains also.
Absolutely.
Yeah.
Anything and
Cost
Yeah.
also.
Yeah, so same thing, like every year WHO comes out with the recommendations for influenza vaccine strains. So like sir said, influenza A you have H1N1, H3 and 2. Influenza B you have the Victoria and the Yamagata strain. Because of COVID pressure, Yamagata strain has not been detected for the last 5 years. So now current recommendation is for 25-26 to do away with the Yamagata strain and go back to the trivalent. So
अगर
next
आपके
year onwards,
new guideline,
yeah,
it may
so-
continue for some time more. if आपके फ्रिज में quadrivalent पड़ा है, so might as well use it. Don't return that stock. It's not a must कि कुछ गलती हो रही है quadrivalent देके. So, but next time when you order, you go for trivalent. That is what is important, and the cost has reduced tremendously. The quadrivalent and trivalent half price हो गया. Okay, Dr. Amin, vaccination of infants. So biological response modifiers in pregnancy are nowadays, mothers are having all sorts of rheumatological problems, from psoriasis to rheumatoid arthritis, you name it, and taking rituximab and whatnot. Does it affect the infant who is going to?
It would alter the child's response, and the live vaccines would be contraindicated till 1 year of age. And the other ones can be given according to schedule. Rituximab also, I mean, if it's an older kid and all, I mean, that's for the mother, not for the child itself. And basically, it's for 1 year, all your live ones. Your measles containing vaccine, your varicella, your OPV will not be given. Even your BCG would have to be deferred.
Yeah.
But there are studies which have shown that rotavirus vaccine
could
still be given even if the mother, basically mother is taking it while the baby is in utero, immune response is altered, so they can have serious side effects of giving a live vaccine. But studies have shown that rotavirus can still be given.
Very rightly put. Remember at what time of pregnancy mother took this medicine. If it was taken in first trimester of pregnancy, nothing would happen. Remember that second and third trimester, the transfer to transplacental transfer is tremendous. So be careful of this baby. As Dr. Amin very rightly said, no live vaccines till first birthday. BCG to be deferred till 6 months. It affects the B cell so much, like a stem cell or transplant, everything is washed out. So probably anti-CD20 B cell count needs to be done, but that's too much theoretical. But at least wait for 6 to 8 months for BCG. MMR, chickenpox, all can be given after first birthday. Killed vaccines can be given, but Rota is also an exception which can very well be given. Thus, Dr. Agrawal sir, thiomersal, patients आके पूछते हैं, सोबो वाले patient है कि डॉक्टर साहब इसमें पढ़ा है, now the new, everybody has access to all information. Is it any risk to my baby?
No, there was a lot of scare about the thiomersal around 10 years back. And because there was a correlation that it can cause autism or it may be related to the autism. But actually it has not been proven in the studies. And that's why the current guidelines say that thiomersal or not, it doesn't make a difference. Some countries still, because of public pressure and all these things, they are continuing with thiomersal free vaccines. Vaccines are available, but even if the thiomersal is there, it doesn't make a difference as far as possible.
I think
it is not evidence-based.
It's just for the postgraduates that it contains ethyl, it's a derivative of ethyl mercury, and there was a lot of hullabaloo about mercury poisonings, etc. And US, therefore, since 2000 has, as a precautionary measure, eliminated thiomersal from its vaccines. And moreover, thiomersal, which is like a antiseptic or a antifungal agent, is required more for multi-dose vials, whereas nowadays most of the injections are going to come as single-dose vials. Those which are coming as multi-dose also, if there is thiomersal, it has been shown that there is no increased risk of autism.
Whether it is alcohol or whether it is mercury, ethyl is good, methyl is bad. Same thing,
So it's methyl that's causing the issues and not ethyl. In fact, the dose also when you calculate comes to only 25 microgram per 0.5 ml dose, which is equivalent to people who eat non-veg in a 3-ounce can of tuna. So it doesn't harm you.
And the ethyl alcohol, the mercury, body clears it very fast. It doesn't accumulate. Whereas a methyl mercury gets accumulated. As she very rightly said, it's a preservative which is used to prevent the fungal and bacterial contamination in a multi-dose vial. Most of the companies have given up, but still DTWP, influenza vaccines, still and hepatitis B. Some of the brands, they still use thiomersal. But as Dr. Agrawal has very rightly said, please be confident and reassure the patient that nothing is going to happen. Bhagyashri, what can be done to protect a child with evidence of immunity, with no evidence of immunity for a varicella, exposed to varicella and high risk for severe disease and complications?
Immunocompromised child?
No, suppose a newborn who is also a high risk of, and mother develops varicella maybe 5 days or 4 days before delivery, or you consider a leukemic patient and the sibling develops varicella. Both situations you can tell me.
So in such a case, you would have to resort to giving varicella zoster immunoglobulin.
So for a newborn, which is a risky period?
The first, you have to watch out for the, basically within the first 4 to 5 days, you will have to
mother getting 5 days before or 2 days after delivery. So newborn, how would you protect?
With varicella zoster immunoglobulin?
Not available?
IVIG you could give, or
Plain IVIG will do.
Plain IVIG, single
200
dose, 400 milligram.
200 or 400 milligram.
Single
And
dose. Or
would you give acyclovir to this child?
Or acyclovir, 20 milligram per kilo per dose, 4 times a day for a week.
Is it immediately or maybe after 7 days?
It is 7 to 14 days.
Yeah,
It is
so
7
it
to
has,
14.
need not be given immediately after 7 to 14 days. And Bhageshri, your photo, a leukemic child, and the sibling develops varicella. I have not, the child never had taken vaccine before. So now how would you protect me?
Again, you will have to give immunoglobulin, and the sibling has developed varicella.
Yeah.
One is, of course, you will have to separate, but he would have already got exposed, so will require varicella zoster immunoglobulin.
I think that when they are in the remission phase, I think very important to understand that they should, because any leukemic child to get varicella, or in fact any immunocompromised child, it's a disaster to have. So let's protect them. So vaccinate as and when the opportunity comes, and all children, siblings, and even the child in remission should be vaccinated. I mean, a child is inadvertently administered MMR-IM, which is supposed to be given subcutaneous, or the other child, hepatitis B, is given subcutaneous, which is supposed to be given IM. What should I do?
So an MMR going IM is not so much of an issue. That is still acceptable. But hepatitis B, even subcut cannot be counted. Because these vaccines which have adjuvants with them, they need to be given IM. So the subcut dose will not take up, and that's why that's not to be counted. Most of your live viral vaccines, even if they're given IM instead of the subcut, they are still acceptable. So even your varicella, if it's given IM, it's not a problem. But your IM specifically hepatitis B, and I think
there are 4 vaccines where you have to remember that route matters, the IM route. That is hepatitis B, human papilloma, rabies, and inactivated influenza. In these 4 cases, they have to be given IM. If they are not given IM and by any other route, it would be an invalid dose.
So subcutaneous being given IM is perfectly all right. So that is to be remembered. But even if this IM goes subcutaneous, as he said, that because aluminum adjuvated, so probably the risk of side effects would be more, and the absorption, the immunological effect of that vaccine would be much less. And very careful, rabies is life-saving vaccine, so be extremely careful. Hepatitis B is another one. HPV is another one which can. Hepatitis A, if something like this happens, it's okay, but not the other vaccines because of the reasons told by the panelists. So let's go to Dr. Agrawal, sir. I have misplaced the diluents of MMR vaccine, but I have a lot of distilled water or 0.9 NS. Is it specific to the vaccine?
It is not advisable. Only the diluent which is supplied with the vaccine, that should be used, because many of these diluents contain the preservatives. And MMR, it is mentioned as a distilled water, but it is actually a buffered water, which has a pH of around 7.4 rather than pH of 7. So it is better that you use the vaccine diluent which is supplied with the vaccine.
I would also say strict no, capital NO, because diluent is specific to the vaccine, is always coming with the vaccine, and maybe anything. It may not just be distilled water, it could be NS, so it's vaccine specific. So you cannot change any diluent and give it with any vaccine.
So they're all so particular about it. Please do not change, no replacement, nothing is allowed. Remember, now the new vaccine is coming for dengue fever, and there the diluent is going to be 0.25 NS, not even 0.9, 0.45 तो available रहता है. 0.25 है, which is not available also. So it is all very diluent specific. So let's be, whatever comes with the vaccine has to be used.
Yeah, sometimes it may be an adjuvant also. Sometimes it may be a preservative. Sometimes it may be just a distilled water. So it's specific to the vaccine. You cannot interchange and use any diluent for any vaccine.
Sometimes your ILR would be flooded with vaccines or boxes and you cannot keep it there. So you are allowed to use diluent, keep outside, not in 2 to 8 degrees, but before use 24 hours before, it has to be again refrigerated. So these are the practical points one should remember while going ahead. Now, Bhageshri, can the diluent, so we already talked about it, sorry. A child is overdue for DPT, IPV, MMR, varicella, typhoid, hepatitis A vaccines. Can we all, Dr. Saab, ये सब इतने एक दिन दे देंगे? कहाँ से मैं नेपाल से पैसा लाऊँ? क्या करूँ?
Why are you stuck on Nepal? Okay, so technically, I think all these vaccines can get administered on the same day, but of course, you have to talk to the parent about the parent's temperament. If the parent is not very happy about giving, ideally, if you administer all on the same day, if they are,
Anything
you are
happens
not
to the
going
immunological
behind schedule.
response?
Nothing happens to immunological response. Only you have to be knowing which sites you have to administer which vaccine. So there are specific sites where you administer specific vaccines. So on the right thigh, on the left thigh, yeah.
Only exception is Prevnar 13 and Menectra.
Yeah.
They should not be given together. All other vaccines can be.
So very important to understand, because these hyposplenic patients or splenectomy, we are giving both these vaccines to prevent the infection with encapsulated organisms. It is always the conjugated vaccine which is given first, followed by Menectra, which is given 4 weeks away, but not for Menveo, only for Menectra. The other 2 vaccines which cannot be given together are again PCV13 and PPSV23. They cannot be given together. In an immunocompromised child, they can be given 8 weeks apart, but in an immunocompetent child, it should be 1 year away that these vaccines can be given. A child receives, MMR in the morning. अरे भूल गए लेकिन शाम को वैरिसेल अभी देना रह गया डॉक्टर आपने तो कहा था लाइव वैक्सीन से एक ही दे सकते हैं या फिर 4 वीक अपार्ट कैन इट बी गिवन व्हाट इज दिस साइमल्टेनियस एडमिनिस्ट्रेशन
So the simultaneous administration counted as a 1 clinic day, and it's clearly said 6 hours.
Okay.
So if it goes beyond 6 hours, patient has come in the morning 10 a.m. and comes in the evening 6 p.m., you'll have to defer it 4 weeks.
3:30 बजे आएगा तो चलेगा.
तो चलेगा. I mean, these are numbers which are there, so you need to respect that. And I'm sure the patients will accept
I think the question comes only in case of live vaccine, and it's very rightly said, please remember this figure. मैंने भी काफ़ी रिसर्च करने की कोशिश की कहाँ से 6 घंटा आए, but I could not find it, but it is given. Simultaneous is 6 hours. So 9 बजे और 3 बजे आ गया तो ठीक है, 3:05 में आया 4 हफ्ते के बाद ही आ जाओ. So especially for live vaccine we have to be careful. Dr. Agrawal, 9-month-old received MR. गवर्नमेंट में गया एमआर वैक्सीन ले लिया अरे भाई समझ में आया मम्स भी चल रहा है मुंबई में बहुत एमएमआर देना डॉक्टर साहब आज एमएमआर दे दीजिए
See, theoretically it can be given after 4 weeks. But somehow I feel that at 9 months MR is basically a dose which is not very effective. And this child is going to get 2 other doses at 15 months and then around 5 years. So it is better, there is no need to just, we can counsel the parent that next dose you give the MMR, third dose you give the MMR, that will take care of.
So you have to basically explain to the parent, he is having a FOMO, fear of missing out on the mumps vaccine, but explain to him that the epidemiology of mumps in children is usually infection occurs between 5 to 9 years. So like sir rightly said, he can always opt for the next 2 doses of MMR instead of MR.
So for the PGs in exams, you give the answer what sir said before, that it can technically and theoretically can be given after 4 weeks. But the other thing is when you enter the practice, that is for that part. So 2 answers were given.
But for the record, BMC is giving only MR and not MMR. And they don't give a dose at 5 years. So the child is definitely going to miss out on that. So at 15, so if the parent is so worried about mumps, let the child touch the first birthday and then take it. Because internationally, everywhere you require a measles containing vaccine, 2 doses to be given after the age of 1 year.
Yes.
So that's the reason. If they're too worried, then after the first birthday, they can come and take the MMR shot at that time.
But this is where probably IIP has to step in, and if we
अरे
really
बहुत
feel...
कोशिश किया कुछ नहीं होता है छोड़ो
Because the
IIP को बीच
cost
में
is,
मत
cost
लाओ
is a concern.
Bhagyashree, for you, a 4-year-old child has completed pre-exposure prophylaxis for rabies with ARV on day 0 and 7, which is recommended. On day 8, unfortunately, very next day, there is a Cat3 exposure with a stray dog. What is the course of action? First, let me ask the audience here, they are sitting, there should be some involvement here. Is choice 1, 2, 3, 4, is it sufficient for protection? Should I continue and complete post-exposure on day 14 and 28? Should I give RIG or monoclonal antibody and continue, or give that and restart the series? Any one of you? How many for 1? Not a 1. 2? एक भी नहीं. 3? And 4? Okay. Jayashree is the only one for 4. Yeah, Bhagyashree, what's your...
I'm also confused in this.
नहीं, बराबर. इसके लिए सवाल पूछ
Because if you see Cat3 exposure, then Cat3 exposure definitely would require a vaccine, it would require RIG. Even though So, but the catch over here is that you have finished your pre-exposure prophylaxis.
Just one day before.
Just a day before. So, usually what is mentioned is that if you have gone beyond the 7th day, so around 8th to 14th day, the antibodies would start getting produced. So, I don't know, on the 8th day, if you have a bite, I think you would still err on the side of giving more than giving less. Though they sometimes say that if any time in the past also, if you have received any rabies vaccine and antibodies are there, giving an RIG would be like wasting the RIG. But I am also not clear on this.
Anybody has other opinion apart from this? Yeah.
See, 7th day dose is practically not effective in this case. That means the child has received only the first day dose. So you have to give the RIG. There is no issue. And it is a category 3 bite.
15th day he was bitten. 15th.
अभी पहले इसकी बात करो और suppose मत करो उसको.
So the studies have shown that it's by day 10 that your actually antibody production is there. So, and rabies is something that is incurable. So always or on the side, I would definitely give the immunoglobulin and continue the series as whatever was on and complete the rest of the schedule.
So yeah.
One more thing I want to say. Continue the series. This means the 4th dose, which is given between 14 to 28 days. It is better to bring it towards the 14 days. Because this patient is not getting the 3rd day dose. So it is better to bring on the 14th day rather than waiting for 3 weeks or 4 weeks.
I think the catch here was whether to give these monoclonal antibodies or not, because the standard recommendation is if you have given 0 and 7, in there is an exposure you are not supposed to give. So even whether you have taken PEP or a PREP. But as Dr. Amin very rightly said about antibody production, for all vaccines, the antibody production starts after 10th day, and in rabies, it can happen 10 to 14 days. There is a delayed antibody production in rabies after giving ARV. So that's why this child is at high risk for this. So that's why it is important to give this. And secondly, the interference study, when it is said that if you give the monoclonal immunoglobulin study was done with immunoglobulin, not with monoclonal antibody, and it was done with the intramuscular dose of immunoglobulin, and that's why that either give it or after 7 days don't give it. Now we are using if it monoclonal antibodies which are infiltrated locally, that effect would not happen. So everybody, as they said, that err on the side, and scientifically it is not just because rabies is scary. Because of this reason, antibody production studies done on RIG only on intramuscular dose interference, local infiltration not shown. So that's why we are giving it. Now, I mean, a 3-year-old child was playing with home dog, was found leaking the saliva around the mouth of the pet dog, no bite noted. After a month, dog developed symptoms suggestive of rabies, expired, and autopsy confirmed the diagnosis of rabies. Now parents have come to advise regarding vaccination. What is the risk? Before, I mean, you start, let the PGs, no risk, some risk, or high risk. Read it carefully and answer. Okay, I mean.
One thing is, where do you come up with these questions? So the thing is, I would have to break it down into different parts. One thing is that the dog has developed symptoms after 1 month. Most of your rabies actual development and dying happens in 10 days time. Most of it, all right? So if that is the case, then that dog didn't have rabies at that time. However, less than 1% is still a risk even after 6 months of a bite. So again, we are talking about a child licking. There is no guarantee that the child has not licked the dog 10 days before also. So that you saw, this you maybe did not even see. So I would still say some risk to high risk, and again, err on the side of caution and give.
So again, licks comes under category 3. But here again, as he rightly said, if there was only that one episode of licking, after which 1 month later the dog developed rabies. So usually it is found that viral shedding in the saliva of the dog will happen 3 to 6 days before onset of symptoms in the rabid dog. So if we say that, okay, from that point of licking till this point, there was no licking episode, then we can be safe. But there can be no guarantee for that. So there will be some risk definitely, though.
Yeah, please.
Yeah.
Kissing.
Yeah. Yeah, but the saliva can contain the virus. Yeah.
Yes.
Yeah, abrasions.
This
Yes,
child
yes,
could
definitely.
be teething as well.
Yes, yes, yes. Yeah. So there are lots of points we need to ask as
That's why
questions in this particular scenario. Everything is not very clear. Very vague.
Very varied.
No, no. Incubation period may
Incubation,
be
no, ma'am.
high. It may be
The
from anywhere from 8
onset
days
to
to
death.
140 days.
Yeah. But
I will make
No, but the viral shedding in the saliva of the dog happens only before the dog develops symptoms.
Okay.
It is mentioned in Nelson also that
Nelson
only
अभी मत
3 to
करो।
6 days.
मैडम को नेल्सन बताती हो तुम?
मैडम
मैडम,
हमेशा
आगे पीछे-
बताती थी हमको कि show me in black and white. So I am telling that it is from Nelson.
This child did not have aplastic anemia, nor is he thalassemic. So please.
दूसरा chapter
I will say one thing, that if there was a dog at home, the child is always at risk. So it is better, there is always some risk, and it is better to give pre-exposure prophylaxis.
Everyone,
Okay.
that's the major, I think, learning point.
अरे
Everyone
बाप
should
रे,
take the
बेल बज गई, 1 minute. So this is first question. कहाँ से question आ गया? तो let me have a honest confession. I was in one of the panel with Dr. Kasi, and there he had put this question. So that is number one. Number two, the answer to this question is there is no risk for this child, and what both of them were trying to say was right. That the incubation, when the child, the dog develops symptoms of rabies, 3 to 5 days before the rabies virus comes to its saliva. The dog has rabies, the virus travels to the spinal cord, then from there it goes from the brain, it comes to his salivary glands, and then from that point onwards he becomes a rabid dog which can transmit rabies to everybody. And that can maximum happen 10 days before. So 3 to 5 days is usually, but 10 days is maximum period. This child had this licking thing had happened 1 month before. So theoretically the answer to this question is this child does not have any risk. हाँ देने का तो दे दो ना मैडम उसमें
Lots of additional scenarios which we can think of in this.
अग्रवाल सर हम लोग 50 के ऊपर है हमको कुछ वैक्सीन बताइए क्या क्या लेना चाहिए वेरी इंपॉर्टेंट बिफोर द फाइनल बिल कम्स
This is only for those who are above 50. Mostly the above 50 are there.
नहीं रेसिडेंट्स है
अच्छा है residents.
मम्मी
So,
पापा भी above 50 होंगे.
The most important thing, the vaccine above 50 is Shingrix, Tdap, and PCV. These 3 vaccines should be taken for with all of us. Because, and influenza of course, annual influenza doses. Shingrix, because as the age increases, the risk of the herpes zoster increases. And now the vaccine is available, so we have to take the 2 doses at the 2 to 6 months interval. A single dose of Tdap, because I think we have not taken the Tdap
Yes,
for
you are absolutely right.
lifelong, so we have. No, not.
Yes,
no,
of course.
No.
Of course,
Madam,
of course, 2 doses.
This is question, not practice.
अरे बिल्कुल सही because let me tell you what he's saying is.
I am less than 50.
1 in 3 can develop after the age of 50. So it's very dangerous and extremely painful, and post-herpetic neuralgia is disastrous. And 90% of vaccine is preventive in not only protection, but also even if you have symptoms, the severity comes down. So shingles is a must for everybody above 50, 2 doses 2 to 6 apart. Tdap is a must, annual flu is a must, PCV is a must. These are the vaccines as of now. बिल्कुल कुछ थोड़ा सा दर्द होता है लोग बोलते हैं मुझे तो कुछ भी नहीं हुआ
Pain. Shingrix is pain.
In fact, we transported to my in-laws in Nagpur. तभी वहाँ पे मिल नहीं रहा था. We sent them there and asked them to take it because my mother had it and it was really bad. So
have a 2-day holiday. Take it on a Friday, and PCV 20 is available now for us.
yeah, quickly 1 question, 1 or 2 questions I'll just take because these are the sponsors. So RSV monoclonal के बारे में. So what is the take on that? Because we have 2 types of palivizumab and nirsevimab. I mean, can you just quickly tell for pediatricians, shall we start using it right now to my all babies? Palivizumab was only high-risk babies. Now they say every newborn baby deserves to take nirsevimab. Your take?
I mean,
have you started telling your patients?
I have started telling my patients. Nobody has come up to say yes to it
Are
up till
sobo wale ho?
But I heard a very interesting thing. The last day, cut down 1 day of your NICU stay and give 1 dose and gone. The nirsevimab was actually brought down the cost tremendously. single dose. If I may say the charge, it's only 25,000 now.
20 तक आने वाला है.
25,000, and if you take the 1 ml, you can even divide it between 2 kids, though they don't recommend it that way. But, I mean, the risk-benefit ratio is far more than anything else. Palivizumab, the problem was 3 vaccines and going on and costing almost ₹1 lakh.
So protection is only for 1 season.
And protection only for 1 season.
So second, so
Yeah,
have you started
apparently
using it?
palivizumab is now going to go
No,
out.
बात ही मत करो,
It's only
nirsevimab मत करो.
nirsevimab. And recently my niece delivered through IVF twins at Bangalore, and she was told to take nirsevimab before discharge from hospital. So they are advocating now. Means we don't deal with those type of patients, but it is recommended in less than 8 months old babies generally. And especially in preterms, etc., you should probably...
It's less than the cost of an NICU day stay.
Especially
So
they say
definitely.
when you are approaching the RSV season, as they say, between October to March,
Correct.
you are born.
But we have 2 seasons, monsoon and winter. So it becomes very difficult to say that.
Yeah.
I think the point is just we wanted to tell you that nirsevimab is here, available. If the patients ask you, you must be aware of the answers that whether to give it or not. So it is safe and it can
The
very well be
MRP
given.
is 37,000 incidentally.
Yeah, quickly the last question.
About dengue vaccines, you
No, dengue ठीक है, आने दो उसके बाद में. Now so many of these vaccines are there for PCV, and I may just display it. I have 2 10-valent, I have 4 13-valent, I have 2 14-valent, and the 20-valent has also come. Dr. Agrawal, your take, which should I use?
See, even the 10 or 13 is okay. It doesn't make much difference if you increase the 1 extra, this thing, and 20 is not licensed for the children. So basically, PCV 13 is good. PCV 14, if the patient wants to give the extra coverage for 1 strain, fine. But the cost difference is almost double, more than 2 to 2.5
नहीं इतना नहीं है, थोड़ा बहुत.
9,000 or something, na?
नहीं. PCV 14 इतना नहीं है. They are at par. So these two, Pneumovax 13 and Pneumoshield are at par. Your take,
No,
Madhuri?
I have on a lighter note, pneumococcal vaccines
Lighter
resemble
for the pocket
Apple
or-
company's iPhones, which every year they will come out with one new version.
Hey, come on.
No. It's not. So the thing is, we are going on a curve where we are controlling the pneumococcal disease gradually. For a government setting, your PCV 10, the Indian one is very good enough because it covers the commonest strains in India. PCV 13, the one that we've been using for ages, all of them are equally non-inferior. That's how they've come in the market. So the PCV 13 is the maximum, most robust data, lots of data and all. That's available. 14, the problem is your toddler studies are not yet available, though they have been submitted. That's what I read last. And we should be coming out with it. 15 is also there, but 15 is not going to come. And 20, obviously, once it's
21 will
approved,
come.
then 21 will come.
Yeah, please.
National Technical Advisory Committee for Sickle Cell, and we have reviewed so many articles and literature extensively, not found data to support which vaccine would be correct for the Indian population, because Indian data is lacking. ICMR has very flimsy data, not much. So I don't think we can say based on Indian data. It is based on American data.
Ma'am, it's a extrapolation from
Prevalence.
Gambia.
So that's what.
Gambia.
So it is not Indian data. And what is discussed is always highest valency if you cover with, then you don't have to give PPSV 23 to these children.
So even what we were talking about, the adults, they can very well take Prevnar 20 instead of what you were
Exactly.
So if you take that, then PPSV is, if you take
Is not required.
बंद किया क्या किसी ने?
नहीं मेरा तो चालू है.
अच्छा देखो मैडम पार्शियलिटी है डाफपाल में इधर ही Okay, so I think I would just conclude by saying what is important to understand. First of all, the vaccine has to be licensed in the country. The other vaccines have to show non-inferiority because Prevnar 13, the number of studies and equally matched by Synflorix, they are unmatched. So any new vaccine player will not be able to do so many studies. So they have to just show non-inferior. It's perfectly okay. That is number 2. Number 3, as you said, 22F, 33F, if there is a 1.5 to 2% extra advantage, if they want to take it, it's fine. 20 and 15 are right now not there. So seroprevalence, which is there in our country, most of these vaccines are covering this, including the Pneumocil, which is there, or a Prevnar, or this 13 or 14. So they can very well be used. And finally, it comes to cost and convenience. So cost, it depends. The patient is taking HPV vaccine also. So let's not get into the details of that. And if you have given proper consideration all these factors, I'm sure we will be able to take a wise decision for the patient sitting in front of us. Thank you so much, my wonderful panelists. Thank you all of you that for your patient hearing and waiting for till 5:50. Oh
Thank you
God.
for the interesting questions,
Thank you.
Upendra.
Thank you.
Thank you so much, sir, for this interesting and interactive session. I would request Dr. Sadhna Zope to present the moderator and our panelists with a token of appreciation.
If I may add something for at least for the PGs, all these vaccines are wonderfully discussed on Vaccine Samvad. It's there on the MahaAP YouTube channel. Each vaccine given 1.5 hours. Go back and see it. You will love it.
Thank you all. Finally, I would like to officially conclude the CME. Thank you to all the faculty, speakers, organizers and delegates for attending the CME and making it a great success. I request you all to kindly wait and rise for the national anthem, and following this to join us for high tea.
So national anthem.
National anthem.
You're going to sing or it's going to be played?
It will be played.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
भारत माता की
Jai.
जय.
Thank you and have a great day.
Great evening ahead. Very wonderfully done.